Can you count how many books, pages, and papers you have studied to be where you are now, who you are now? Can you count the hours and nights spent in hospitals? Your successes and failures? Can you count how often you made patients smile? Can you count the smiles you received? Can you count how many people you have met, lives you have touched, families you have helped? Can you count the families you kept together, the moments you gave to them, their welcome home parties, the many more moments they can spend together? He counts on you. They count on you. For 5 years, you and over 660,000 patients worldwide have counted on Repatha to help lower LDL-C levels, have counted on us to help reduce LDL-C levels to the recommended ESC/EAS guideline targets. You can keep counting on Repatha to help protect your MI patients from another life-threatening CV event.
Hello, good afternoon, everyone, and welcome again to this last session of the CardioOncology course. My name is Francisco Inguita, and I will be chairing this first session. So it is my real pleasure to welcome you here again, and it's my real pleasure to introduce Dr. Nuno Cortés Diaz. And he is a specialist in cardiology, and he has been focused specifically in arrhythmology, electrophysiology, and cardiac pacing. And now he's going to talk about something that it is a very hot topic today in cardiology, which is the role of non-coding RNAs in the context of cardio-oncology. So Nuno, thank you very much. The stage is yours.
Hi. Hello, everyone. Thank you, Professor Francisco Inguita, for your introduction. I want to start by thanking to the organizing committee for the kind invitation to participate in this session. It's my greatest pleasure to take this opportunity to discuss with you very recent evidence on the role of non-coding RNAs in cardio-oncology. I will start by presenting the most important families of non-coding RNAs. We will discuss their participation in the pathogenesis of cancer, cardiovascular disease, and very important, in the mechanisms of chemotherapy-induced cardiotoxicity. And finally, we will review very recent evidence on the use of circulating RNAs as biomarkers for the diagnosis and certification of cardiotoxicity. As you all know, the human genome is composed of protein-coding genes, which represent a very small proportion of the genome, around 2 to 3%, and the vast proportion of genes that give rise to non-coding RNA, representing as much as 98% of the transcriptional output. The non-coding RNAs are usually divided on the basis of their size into small and long classes, comprising many different families whose functions on the cellular biology are starting to be revealed. The most important families regarding cardiovascular physiology and disease are the microRNAs, long non-coding RNAs, and circular RNAs. MicroRNAs are small molecules composed of 18 to 20 nucleotide sequences. They are involved in the post-transcriptional regulation of gene expression by interacting with complementary sequences in the 3' untranslated region of the target messenger RNA, thereby suppressing protein translation in a very targeted way. it's important to recognize that microRNAs participate in a tissue-specific manner in very complex regulatory networks with different regulatory levels, various players, and multiple targets. For instance, each microRNA has the potential to target multiple different messenger RNAs. That means that a certain microRNA may inhibit different genes related to different metabolic pathways or may inhibit a certain pathway at different levels, eventually producing a stronger biological effect. On top of that, different microRNAs may act simultaneously on the same messenger RNA, producing a stronger translational repression and eventually a stronger biological effect. It has been shown that microRNAs modulate critical biological processes, including cell proliferation, apoptosis, hypertrophy, and inflammation. And many studies had implicated the aberrant expression of microRNAs in the pathogenesis of cardiovascular diseases and cancer. Furthermore, it should be mentioned that the same microRNA could function in a context-dependent and tissue-dependent manner as cardiomere, angiomere, or oncomere. The long non-coding RNAs are molecules composed of more than 200 nucleotides that form a very heterogeneous group with different mechanisms of action. Some long non-coding RNA act at the nucleus as epigenetic regulators, influencing gene transcription and modulating the location and function of proteins. Some others act at the cytosol as molecular sponges, titrating microRNAs away from their natural messenger RNA targets. That means that long non-coding RNAs may provide a counter-regulatory mechanism inhibiting specific microRNAs by preventing them of doing their inhibitory action at gene expression. Circular RNAs are the most recently discovered family. They are RNA rings formed through alternative back splicing of protein coding exons. They are involved in transcriptional and post-transcriptional regulation of gene expression, ranging their function from host gene regulation to cellular scaffold. Recently, it was found that circular RNAs might also work as sponges, binding to microRNAs and repressing their function. As microRNAs control a large set of biological processes, circular RNA sponge activity will also affect such biological pathways. Therefore, these various families form a complex multi-layer regulatory network that seems to be critical in the pathophysiology of various diseases. In fact, it has become evident that the expression of these molecules changes during disease progression, and aberrant non-expression or overexpression of specific species has been associated with the pathophysiology of cancer and cardiovascular diseases. Just to give you an example, our group recently investigated the overall expression of messenger RNA, microRNA, and circular RNA in tissue samples collected in the left atrium of patients submitted to cardiac valve surgery with atrial fibrillation. We observed relevant changes of the overall expression pattern with the progression of the disease. The expression of some microRNAs increased in patients with permanent AF in parallel with the down expression of their predicted messenger RNA targets. But the dominant feature of AF progression was the down expression of numerous microRNAs. And by studying the expression pattern of circular RNAs, we found that at the same time the microRNA expression decreases, various abnormal circular RNAs started to be expressed in the atrial myocardium. And by analyzing the nucleotide sequence, we predicted that abnormal circular RNAs might be acting as sponges to the down-expressed microRNAs. In other words, the dysfunction of the non-coding RNA regulatory network may be very important in AF progression. MicroRNA dysregulation also occurs in cancer. The first description was done back in 2002 when it was found that a genomic region frequently deleted in chronic lymphocytic leukemia harbors a cluster, and the deletion of that cluster promotes the overexpression of the BCL2 oncogene, thus favoring cancer progression. Since then, it has been documented that microRNA play roles in all landmark processes in cancer biology, modulating tumor growth, invasion, angiogenesis, and immune response. Additionally, tumor microRNA profiles have been found to be useful to identify cancer subtypes and to predict survival. The role of non-coding RNAs in cardio-oncology started to be unveiled very recently and is still a matter of great debate. As you all know, doxorubicin is widely used for a variety of cancers, such as breast cancers, lymphomas, and leukemia. And this drug is also well known for causing cardiac toxicity, with left ventricular dilatation, systolic dysfunction, and congestive heart failure, which impacts long-term outcome. Several studies have suggested that apoptosis is the predominant cellular event in doxorubicin-induced cardiotoxicity. In this setting, apoptosis may be the result of different mechanisms in which non-coding RNAs are critical players. For instance, doxorubicin-induced cardiotoxicity is characterized by mitochondrial dysfunction. You must remember that cardiomyocytes have high mitochondrial abundance, and therefore these cells are extremely vulnerable to agents that interfere on mitochondrial metabolism. Over the last 5 years, many different microRNAs have been implicated in doxorubicin-induced cardiotoxicity. It has been observed that upon doxorubicin treatment, the expression of miR-532 increases. This seems to be relevant since miR-532 targets the ARC protein, which promotes mitochondrial dysfunction. At the same time, the expression of miR-499 was found to decrease, leading to upregulation of the transcription factor P21, resulting in mitochondrial dysfunction and apoptosis. The understanding of the roles of long non-coding RNAs and circular RNAs in doxorubicin-induced cardiotoxicity is still at an initial phase. Preliminary evidence suggests that the long non-coding RNA P21 might be relevant, and it was shown that suppressing this long non-coding RNA attenuates mitochondrial dysfunction and oxidative stress in this setting. However, it should be highlighted that all these relevant observations came from in vitro studies, so precaution is required, and further investigation is clearly needed, proving their relevance in human disease. Non-coding RNAs can be detected in the several body fluids, including the blood, urine, and saliva. Their presence in the fluids is a natural process not only related with cell death, but is also the result of active secretions through microparticles, high-density lipoproteins, and exosomes. In fact, recent evidence suggests that non-coding RNAs may act as genetic hormones, being transported in the blood up to distant organs and modulating the gene expression in the target cells. Incorporation of the long non-coding RNAs and non-coding RNAs in extracellular carriers confers them great stability in the blood, which is a requirement for a biomarker. The circulating non-coding RNAs present robust expression patterns and are expressed in the tissue-specific manner, which are also very important features for biomarkers. Therefore, circulating microRNAs are being extensively explored as biomarkers for diagnostic purposes and for prognostic certification in different cancer types. Just to give you an example, in this study, Wang and colleagues collected serum samples from almost 400 patients with advanced non-small cell lung cancer and found that the circulating levels of a group of 17 microRNAs were able to identify the patients at the highest risk of death. Circulating microRNAs have also been the focus of greater interest in the setting of cardiovascular disease. Back in 2010, D'Alessandro and colleagues found that some microRNAs typically expressed in cardiac tissue, namely miR-1, 133A and B, 208, and miR-499, rise in the bloodstream early in the temporal progression of myocardial infarction. And these researchers suggested that circulating microRNAs could be even more sensitive and specific than troponin. However, it should be mentioned that troponin was quantified at a time using the first generation of troponin tests. More recent studies applying high-sensitive troponin assays did no longer confirm such promising results. Therefore, the focus has moved from the diagnostic field to prognostic stratification. Our group explored the value of circulating microRNAs as prognostic biomarkers in patients with ST elevation acute myocardial infarction. We studied 142 patients in whom blood samples were taken at the time of urgent cardiac catheterization. We found that the miR-122-133B ratio is a very interesting biomarker for the early prognostic stratification. The event-free survival was significantly worse in patients with a high miR-122-133B ratio. the risk of death or myocardial infarction was almost 9 times higher, and the risk of adverse cardiovascular events was 4 times increased. But interest of circulating non-coding RNAs as clinical biomarkers extends to many other cardiovascular diseases. This diagram comes from another paper from our group in which we systematically reviewed the evidence relating circulating non-coding RNAs and cardiovascular diseases in terms of diagnosis, prognosis certification, and evaluation of the treatment response. You can see how dense is this diagram, which means that some microRNAs are simultaneously related to various processes critical to cardiac remodeling and tissue healing, and therefore associated to several cardiovascular diseases. This study, conducted in Brazil, evaluated 56 female patients with breast cancer submitted to doxorubicin and followed them during 1 year. 3 weeks after each doxorubicin cycle, blood samples were collected for troponin and microRNA quantification. Cardiotoxicity was observed in 18% of women. As you can see in these graphs, the circulating levels of cardiac enriched microRNAs dynamically change over time, and the magnitude of change was higher in the women that subsequently presented cardiotoxicity. Among the several circulating microRNAs, MIR1 was the best prognostic predictor. Its accuracy to predict cardiotoxicity was significantly better than troponin. Furthermore, it was able to detect toxicity at a very initial stage of the disease. Please note that just 3 weeks after the second cycle, the MIR1 levels were already higher in the group of women that suffered from cardiac toxicity 1 year later. Since then, several studies involving patients submitted to chemotherapy and many experimental studies in animal models reinforce the relevance of non-coding RNAs as biomarkers for the early detection of cardiotoxicity. Up to now, the most promising biomarkers are the cardiac-enriched microRNAs, namely MIR1, 133A and B, 499, and the profibrotic MIR29 family. So I would like to conclude by saying that it is extremely important to understand the mechanisms of chemotherapy-induced cardiotoxicity to develop methods for the early detection of cytotoxicity and therapeutic applications. MicroRNAs, long non-coding RNAs, and circular RNAs have been shown to have significant functions in the cardiovascular system and are likely to be also relevant in the pathophysiology of cardiotoxicity. Finally, non-coding RNAs are promising biomarkers, but further studies are clearly needed to clarify their value for the timely detection of chemotherapy-induced cardiotoxicity. Thank you very much.
Thank you very much, Nuno, for this very nice and very complete talk. So I will open now the microphones to the people, if there is any question around.
Please, I just want to also congratulate you and to thank you by being the leader of the team that was involved in this work. And many of the things we had the opportunity to share are the result of this interaction between the cardiology field and the basic research field applied to the problems we are facing in the clinical practice. So thank you for involving your team in this comprehensive work.
You know that you are very welcome, and I have to say to the audience that cardiologists were always very interested in this kind of molecular biology field and genomics and transcriptomics. And I think I had a lot of fun with you and with your team as well. So, and I think that we can progress further. So you are very welcome, Nuno.
And on top of that, I want to add that clearly the results I had the opportunity to share I think show that we have a window of opportunity if we use different biomarkers to search for doxorubicin in this cardiotoxicity. During many years, we were always searching the same type of biomarkers. We were looking for image markers of cardiotoxicity, and we were exploring usual parameters. And what we are now doing is to dive deeply on the mechanisms of the disease. So if we could start exploring not the results of the disease, but the mechanisms of the disease, eventually we will have the chance of finding something relevant. Yeah. And I think that microRNAs are really an example of that. We are not exploring just the result, markers of fibrosis, markers of dysfunction, markers of cell damage. We are trying to start to understand what is going on when doxorubicin induces myocardial dysfunction, and we are trying to use that knowledge in a clinical, meaningful way.
Yes, I agree totally. So,
can I say something?
Yes.
Yes. Okay. But first of all, I have to congratulate you. When I knew you could do it brilliantly, when I challenged you with this team. And I have a question for you. As well as I understood, the microRNAs are essentially biomarkers for diagnostic and prognostic purposes. Well, could these cardiac microRNAs become therapeutic targets and become, so to speak, game changers for this disease?
Ingita, do you want me to start?
Yes, of course.
Yes. So obviously there is also a window of opportunity in the therapeutic field, and that window of opportunity is already being used to treat some diseases. For instance, this type of technology, the use of microRNA biology to interfere in the gene expression, is being used in clinical practice to treat a very Portuguese disease, which is familial amyloid polyneuropathy. One of the drugs that are today being tested in clinical trials, miravirsen, precisely acts using this type of interaction, mimicking the function of the microRNAs in order to suppress the abnormal expression of transthyretin. And that very same concept was attempted a few years ago on the treatment of C. hepatitis with using as a target the miR-122. So clearly, microRNA biology can be used in a therapeutic way. Obviously, there is still a huge gap on the knowledge we have that has to be narrowed before we jump from the biomarker research to the therapeutic use of microRNA. So we must get much more knowledge before we can advance that way. But clearly, there are many interesting things on the microRNA biology that make them interesting targets in therapeutic ways. And we are seeing that the RNA biology in different terms is being employed in clinical practice. And we have now a very good example of that on the use of RNA biology, not microRNA, but other RNA species as vaccines for the COVID-19, as you know. So the RNA biology in its plenitude has many therapeutic applications. So different species of RNAs hack in different ways, and we should choose the appropriate one for the therapeutic application that we need. Do you agree on that, Gita?
Yes, of course, I agree. I think that it is a good example, the case of the vaccines recently developed, and also I have to say that I always tell these things to my students, that when you are dealing with non-proliferative organs like the heart, so you have to think that these organs are very dependent on these regulatory events that you describe. So the brain and other non-proliferative organs are very dependent on these non-coding RNAs. So these non-coding RNAs are in the core of many diseases. And of course, the more we will know, the more we can use in therapeutical purposes, of course. Okay, so I totally agree with you. Yeah. I think that still we have 5 minutes of time, so please don't be shy and open your microphone and ask questions. We are totally open to interact with you if you are interested in this field. So we will be very happy. We will be very happy to join your efforts and to listen to you and to try to solve your problems. So so please let us know. Okay. So looks like everything was very clear.
So, Manuela, you told us that there was one session that jumped from the early period to the afternoon.
Yes, but now I think we already have the Professor Ludmila online. So
yes, I'm here. I'm here.
Okay, thank you. I think we could move to the other lecture, and I'd like to thank you very much, you and Angita, for this section. This is completely seems to be out of the box, but it's not. Probably in the next year we'll have a keynote with you with this team again. Okay.
Thank you very much. Thank you.
It was a great pleasure.
Thank you.
Congratulations by the course.
Thank you. Congratulations.
Okay, let's move along then. And it is my great pleasure and honor to introduce Dr. Ludmila Ajar, who I guess actually needed no introduction at all. She is an associate professor of cardiologist at the University of São Paulo. She has also been very deeply involved in the field of cardio-oncology and also intensive care medicine at also world-famous hospital, INCOR. And so, Professor Ludmila, the floor is yours, please.
Thank you very much, Miguel, for your words. Thanks to Professor Fausto and Professor Manuela for this wonderful invitation for this two-day course of the best of cardio-oncology. Thank you very much for this pleasure to be here talking to you. Much about prevention, but we have a few data on cost of effectiveness. So we're opening and talking about cost effectiveness. So I'd like to ask you that I would like to share my slides, okay?
So Professor Ludmila is asking to share her slides. I just asked our technical support to give her a hand. Okay, thank you.
She can do it.
So, hello everybody. The topic of my talk is cost effectiveness of cardio-oncology clinical assessment for prevention of chemotherapy-induced cardiotoxicity. As we know, a few decades ago, the first report of cardiotoxicity came from the daunomycin, an anti-tumor antibiotic, when we had the description of children and adult patients which receiving these drugs, they had tachypnea, tachycardia, heart failure, and hypotension. So in 1971, we understood better that we are talking about a dose-dependent cardiotoxicity related to these drugs. Patients presented irreversible damage in the heart, in the mitochondria, leading to heart failure. A few years after, we receiving radiation, and males, they had increased risk of cardiotoxicity, as was the case of patients who presented other heart disease. So we understood for the first time that cardiotoxicity related to doxorubicin and its derivatives, it was related to previous and known risk factors. In 2004, Professor Cardinali showed that we could predict heart rate with measurements of troponin, as was the case of this study, when she showed in more than 700 patients that if we assess the troponin prior to chemotherapy and a few days after chemotherapy and also 1 month after chemotherapy, we could detect early who were the patients who would develop cardiotoxicity and heart failure. And so maybe these patients could be patients who would most benefit from the strategies of prevention, such was the case with ACE inhibitors. In this study, patients randomized to ACE inhibitors, if they had positive troponin, they had a lower chance of developing heart failure, and they had a lower incidence of cardiac heart and other adverse effects related to cardiotoxicity. First time, a few years ago, Daniela Cardinali showed that there was a subgroup maybe most benefit to be included in the randomized clinical trials and to be the patients that we would study prevention strategies to also with the follow-up of 5 years, that the most cases of cardiotoxicity related to anthracycline drugs happened in the first year. Most part of cases were related to partial recovery, and 11% of patients presented full recovery. In this study of more than 2,000 patients. So we could understand that the most serial follow-up should be assessed in the first year after chemotherapy. So this is very important when we are launching resources and allocated funds to have a huge program of cardio-oncology. When and how should we allocate resources? First, we must know the disease. We also could understand that childhood cancers in the future are patients who will present a high incidence of cardiotoxicity. Of course, we could now detect other and additional risk factors such as hypertension, diabetes, obesity, and dyslipidemia. And also we could understand that there is an interaction between risk factors and cancer therapy, leading to a higher incidence of cardiovascular events and also mortality. So survivors who have hypertension and past of chest radiotherapy, they have an increased likelihood of 6.1 of coronary disease, of almost 20 times higher risk of heart failure, and 13 times higher risk of valve disease. So we could develop models of follow-up based on cost effectiveness, because now we have the chance to know who are the patients who will most benefit from a serious follow-up in the program and maybe to be included in the trials of prevention strategies. For example, this study we performed at our Institute of Cancer and Coronary Heart Disease at the INCOR, and we included breast cancer female patients who will be submitted to chemotherapy with doxorubicin with a mean dose of 240 grams. And we showed that in 1 year, patients presented an incidence of 13% of cardiotoxicity, detected as the decrease in the ejection fraction of at least 10%. We included these patients in a randomized double-blind control trial evaluating whether carvedilol could prevent cardiotoxicity. We showed that carvedilol cannot prevent the incidence of cardiotoxicity in 1 year follow-up. However, patients who received carvedilol presented a lower release of troponin in the circulation in 12 weeks of measurement of troponin. So in this study, carvedilol was not effective. But when you look to the mechanism, to the involved mechanism of cardiotoxicity, carvedilol decreased troponin release in these patients. So carvedilol did not show cost effectiveness when we look to a model of breast cancer female patients receiving a mean dose of anthracycline of 240 milligrams per meter square. When you look to the field of dexamethasone, we can understand that we have only a few data. We have trials of more than 10, 15 years ago, showing that when we put together all these trials in a meta-analysis that I participate with Dr. Macedo in Brazil, in breast cancer patients, dexamethasone reduced the risk of clinical heart failure without increasing the risk of cancer recurrence, of cancer metastasis, without affecting progression, survival. So it's very interesting to better understand, to study better, which is the final role of dexamethasone, because these trials are very old trials. They have included very heterogeneous population, but what we have until the moment that this is a safe drug that did not increase the risk of cancer recurrence. Maybe it shows that it has cost effectiveness, but we don't have this data yet. We also understood that we have cardiotoxicity related to radiation. And when these patients present all the risk factors, for example, coronary disease, the risk increases at least 7.4% a year. The same we can understand when we look to more years of follow-up, how higher is the dose of radiotherapy, higher is the risk of cardiotoxicity. So what we have until recent years is that in the model of anthracycline cardiotoxicity and radiation cardiotoxicity, we have understood that there are risk factors. And this will show who are the patients who most benefit from the follow-up trials and also randomized clinical trials of prevention strategies. A few years ago, we had a very interesting example of cardiotoxicity when we had the first reports of cardiotoxicity related to trastuzumab. Trastuzumab is a very interesting drug to treat patients with breast cancer, for example, who express the HER2 receptor. In the first studies, we did not have data of cardiotoxicity, but when trastuzumab came to the clinical practice, we had the first description of until 30% of heart failure related to this drug. And so now we can understand that we have until 30% of patients showing decline of ejection fraction and about 2 to 4% incidence of severe heart failure. But we also could understand that cardiotoxicity occurs during therapy. In the most patients, it's reversible because it's related to transient perturbations of neuroregulin, signaling, of endothelial cell homeostasis. And so we can understand that in most cases, we can decrease the dose or we can stop transiently the therapy and we start the treatment of heart failure, and we have the preserved ejection fraction. In most cases, these patients can be maintained on this therapy, or also they can come again and be back to the chemotherapy. We also could understand that patients receiving anthracycline with trastuzumab, this risk is still higher. So this is the population with higher risk. But in cardiotoxicity, in cardio-oncology, we're also looking for more data to early predict the incidences of cardiotoxicity. This is the case of longitudinal strain. This was the first study showing that patients treated with anthracyclines, taxane, and trastuzumab who presented a decrease in this strain during the follow-up, these were the patients who would present cardiotoxicity in 1 year follow-up. So we now can understand that at the same time, biomarkers and strain and also the risk factors are defined for a few drugs of a few regimens of chemotherapy, they can predict the occurrence of cardiotoxicity. In the case of trastuzumab, we can understand that in most cases, we can maintain the drug or also indicate transient interruption while we treat the patient. And in the end, these patients will recover the decline in ejection fraction. Other models came to our clinical practice, such as the VEGF tyrosine kinase inhibitors, when we see decline in ejection fraction, ischemia, and hypertension. Now we understand that patients who present early in the follow-up the occurrence of hypertension, they are the subgroup who will most present heart failure in the near future, so they become a risk factor group. Now we're looking for detection of factors of the occurrence of myocarditis in patients treated with immune checkpoint inhibitors. We know and better understand that this is not a frequent disease, but this is a fatal disease in 50% of patients who present the severe forms of myocarditis. Now we're looking for detecting predictors, risk factors, such as troponin, such as decline in the strain measured by echo, but this is a very severe and fatal disease. So, as we can understand, cancer therapies can affect the cardiovascular system through multiple ways, with heart failure, valvular disease, pulmonary hypertension, pericardial disease, atherosclerosis, peripheral arterial disease, metabolic syndrome, hypertension, arrhythmia, myocarditis, which will in the end lead to increased risk of morbidity and mortality in these patients. A very interesting model is the model of the clonal hematopoiesis, showing that there are shared pathways between cancer and cardiovascular disease. Both diseases are the great responsible for mortality in all the countries worldwide. We know that low-income countries, such as the case of Brazil, cardiovascular diseases are still the first cause of mortality, followed by the cancer disease, which is not the case in the high-income countries when we know that cancer is the first leading cause of mortality. We have many other studies coming showing the importance of both cardiovascular disease and cancer disease as the most responsible for mortality in the world. So we have lots of research priorities in cardio-oncology in the next years. First, we should try to understand whom and why cardiotoxicity occurs. We must try to personalize risk assessment and management. We are not able to follow up everybody in the same way. We should think about strategies of better understand the phenotypes of cardiovascular disease, the mechanisms of, and also it will lead to models of cost effectiveness. We show that in the end, we're looking to better outcomes in these patients. And we must think this since the beginning, since the design of the clinical trials, such as the case when we have patients in the general, we have patients with low risk. So these patients will be follow-up, such as the usual care. But we have models of risk who will show me who are the patients who will most benefit from these trials, from the prevention strategies. And so these patients will be included in the randomized trials, in the cost effectiveness studies of follow-up. We have many ongoing studies, including cost effectiveness, such as in the case of Prevent Trial, STOP, and PICORI, and RADICOMP, and the other registered already in the platforms of clinical trials. So these trials will come with these answers in the near future. So in the case, we must approach to the cardio-oncology care, looking prior to cancer therapy, during cancer therapy, and also implementing protocols of follow-up after cancer. For this, we must determine who should be referred. We must develop our models of cardio-oncology programs. We must develop and implement evidence-based protocols. And in the end, determine cost effectiveness, which now is a new field in our area, which must be explored in this near future. Thank you very much for your attention. And again, Manuela and Fausto, for the great opportunity to be here in this afternoon. Thank you very much.
Thank you very much, Professor Ludmila, for a wonderful presentation. So I would start by opening up the questions to the audience. To start with, you may pose questions directly. You may also write them on the chat if you prefer. Okay, I guess I'll open it myself. So, Professor Ludmila, we've been hearing a lot about cardiotoxicity for quite some time, and the original studies by Daniela Cardinali are now quite a few years old, and we're still not entirely sure which strategy of primary prevention is best on which patients, whether it's beta blockers, whether it's ACE inhibitors, perhaps even some of the new heart failure drugs that have come about in recent years. And I guess probably the main reason for that is because we've been seeing these relatively small trials, usually single center with few centers, but not quite a very large trial like the ones we're used to seeing in heart failure. So my question to you is, what do you think are the main constraints that are still keeping us as a community from performing very large clinical trials, which could give us a clear answer on who should receive primary prevention and with what?
Miguel, thank you for your great question. I fully agree with you. It's not possible to perform cardio-oncology today based on small trials from 2 decades. I think that what we should launch for this near future is to use our international societies to join us as only one community of cardio-oncology care, trying to have big registers and big international trials, trying to give us adequate answers for these questions. So I think that we should, and I think that we have a few initiatives in these last years. However, we need more, and this starts with groups such as your group, such as my group, that we should be together trying to give these answers for the community.
Thank you. So any further questions from the audience? So I guess that another question that I could also ask you, because this is quite heterogeneous across groups, is the role of biomarkers specifically, right? So some groups are using biomarkers very frequently as part of their primary prevention strategy, others not so much. There's another effect of heterogeneity, which is quite relevant clinically, which is when you're using troponin, which troponin assay are we using? Are you using high sensitivity troponins? Are you using 4th gen troponins, because the high sensitivity troponins are so sensitive? Do you think in your experience that one, are cardiac biomarkers actually useful, and if so, which? And do you think that even if useful, do you think that they're actually cost effective, or do you think that it's just too wide a net?
Very interesting question. We know that, for example, in a continental country like Brazil, we have many models of troponin. When we have to perform these studies, we have to get funds to give the opportunity of all the centers have the same troponin assessed. However, in our institution, we use the high sensitive assess of troponin, because our field is trying to detect the highest number of patients who are defined such the high-risk patients of developing cardiotoxicity. So I think that the ultra-sensitive or high-sensitive troponin, I think it's a new form to detect early patients who are at high risk.
Thank you very much, Professor. Any other questions from the audience? Okay, here's a question from Dr. Andrea Magalhães, Professor.
Good afternoon. Thank you so much for being here with us and for the excellent presentation. And I would like to ask you a very practical question. With the evidence that we have today, for which patients do we start the prophylactic therapy? Or we just, or do you think we just are in the era of clinical trials and not for spread for the whole population?
Andrea, can you repeat your question, because I lost the connection during.
Okay. So I was asking you, with the evidence that we have today, which patients should we treat with a prophylactic therapy?
Now, we don't have evidence to implement prevention strategies in these patients. When we put together all these trials, we have trials with beta blockers, with ACE inhibitors, with AT1 antagonists. However, when we look for this data putting together, we don't have enough evidence to start these drugs while these patients are starting chemotherapy. We need more data. We have now a few small trials showing minor endpoints of superiority, of, for example, with carvedilol or with enalapril, but such as the example that Gail had asked, we don't have a big trial, international trial, with adequate sample size to give us this answer. Is carvedilol effective? Is this a strategy based on cost effectiveness? We don't have this data. We have in Brazil projecting a study with carvedilol with 1,000 patients. We would start the patients inclusion when we had the pandemics. Now we are stopped with this trial, but our idea is to better answer this question based on a study with 1,000 patients, but we don't have this data yet. We don't have evidence to recommend carvedilol or enalapril or losartan or spironolactone to these patients.
Yeah, I totally agree. I think we need to stick on trying to control risk factors and put the patient at the better position possible before starting therapy. Yeah.
Thank you very much, Professor. Any other questions from the audience?
Well, I would like to thank you, Professor Ludmila, for such a great presentation, and it's an honor to have you here. I'm glad you could participate, and I want just to know your opinion about this new concept of reverse cardio-oncology, because of those shared risk factors, and it's a new concept. I would like to know your opinion.
Manuela, may you repeat your question?
It's about the new concept of reverse cardio-oncology.
Okay. Manuela, I think that it's a very interesting topic. We are studying this in Brazil because in the last years, we have much evidence about this. Now we are studying mainly in the heart failure patients, this concept in Brazil. We have now a translational lab, core lab in Brazil, and we are following up the patients, looking for the reverse of cardiotoxicity during a more extended follow-up. So we are studying this in deeping now, looking for analyzing biomarkers and new biomarkers to predict the risk of cardiotoxicity and to predict who are reversible, who are not reversible. So I think this is another field, a new field in cardio-oncology.
Yeah, thank you.
Thank you very much, Professor. We have another question from the audience from our own Lourdes Silva, who is also an expert in heart failure and intensive care medicine here in Lisbon. And she's asking a very interesting question. She's asking about, what do you think about ARNIS, so sacubitril valsartan, as a first-line approach in secondary prevention in the setting of cardio-oncology? Okay, we seem to be having a technical issue because Professor has dropped her connection. Let's just give it a brief pause, see if she can get back online. So bear with me, please.
I don't know, the connection was not really good. So it's better to.
I'm back.
Okay, I think, she's
you're
back.
back.
She's back. Yeah, she's
Okay,
back.
so answering the question of secondary prevention with AT1 antagonists, what we know until now is that primary prevention, we don't have evidence for this, but when these patients develop decline of ejection fraction, of course, we will use in cardiotoxicity the same trials that we use in general cardiology. So we'll treat the patients, but not as primary prevention and not as prevention of patients who do not develop any sign of cardiotoxicity. We don't have evidence for this. We have the CHARM trial, an old trial, and other ones, but we don't have enough evidence to implement a strategy of prevention based on these drugs until now.
Thank you, Professor. Any further questions? Okay, then I believe that we can call this a conclusion. Professor Ludmila Adjar, once again, thank you very much for joining us. Thank you so much for a wonderful talk and a great discussion, and we hope to see you very soon in the future. And we'll keep in touch.
Thank you very much. It was a great honor to be here with you. Congratulations.
Thank you. The honor was ours.
Thank you.
Bye-bye.
So now, with a little bit delay, let's move to the other lecture. Let's move to Joana Rigueira. Joana Rigueira is a young cardiologist, very promising cardiologist, and she works at our department. And now she has a special interest in echocardiography. So I asked her to talk about appropriate uses of echocardiography in cancer patients. Where are we with strain imaging? Thank you, Joana.
Good morning, dear colleagues, ladies and gentlemen. In the next few minutes, we will discuss the appropriate uses of echocardiography in cancer patients, mainly focusing in strain imaging. But why should we discuss cardiovascular imaging in a cardio-oncology course? Well, actually, because these cancer patients most of the times need therapies that had the potential to cause cardiac dysfunction, an asymptomatic reduction in left ventricular ejection fraction, and also overt heart failure. And this is associated with a very poor prognosis in these patients. Nowadays, the perfect methodology for an early diagnosis of this cancer therapy-related cardiac dysfunction, CTR-CD, remains controversial, with several tools being proposed from biomarkers to different types of cardiovascular imaging techniques. I will mainly focus my presentation in echocardiography because it is the most widely used modality that covers most of the cardiotoxic complications of cancer treatment. It is widely available with a satisfactory reproducibility. It is cheap, easy to use, and it is a non-invasive and safe technique. In the literature, there are several definitions of cancer therapy-related cardiac dysfunction. But in the 2016 ESC position paper, the authors establishes a reduction in the left ventricle ejection fraction to a value below 50%, or a significant decrease in the left ventricle ejection fraction of more than 10% as the cutoff to start cardioprotective therapies and to increase the surveillance in these patients. According to this, the left ventricle ejection fraction is the most commonly used parameter for identifying LV dysfunction before, during, and even after cancer therapy. However, the left ventricle ejection fraction has, as we all know, several limitations, mainly in this scenario. First, it has a technique-related variability that can be higher than the thresholds used to define cardiotoxicity. Second, because it lacks sensitivity to detect subclinical changes in cardiac function caused by early myocyte damage due to cardiotoxic treatment. And third, because when it happens, the reduction in the left ventricle ejection fraction is often a late phenomenon. And the literature says that when it occurs, more than 50% of the patients fail to recover systolic function even after starting cardioprotective therapy or other kinds of intervention. And this is where the strain imaging might help in the management of these cancer patients. The strain imaging relies in the basic concepts of the myocardial mechanics, where during systole, myocardial fibers shortens along the longitudinal and circumferential axis and thickens in the radial dimension. Nowadays, the most used technique to evaluate strain in echocardiography is the speckle tracking technology that considers very small points in the myocardium that are called speckles and measure the movement of these speckles along these three dimensions. And the software gives us a number that is the percent change of the LV fiber length from the relaxed to a contractile state. And there are several measurements of strain, and the most used is usually the global longitudinal strain, because it is the best studied, the most reproducible, and also the one that correlates best with clinical outcomes from a diagnostic to a prognostic purposes. So it is important to understand that a normal left ventricle ejection fraction does not exclude myocardial dysfunction in this population. And in the literature, there are several papers that highlight that changes in the global longitudinal strain occur earlier than changes in the left ventricle ejection fraction, and usually at lower doses of anthracycline therapy. It is well known the superior feasibility, sensitivity, and reproducibility of global longitudinal strain compared with left ventricle ejection fraction, with an inter-exam variability of about 6% in the GLS compared to almost 10% in the left ventricle ejection fraction assessment. And according to this, the international societies and guidelines promoted the possibility of monitoring these global longitudinal strain changes during cancer treatment. And this makes the global longitudinal strain an important marker in different points of cancer patients' evaluation, because it might have a role in diagnosing a subclinical LV systolic dysfunction prior to the initiation of chemotherapy, and is also important in monitoring the LV function during the chemotherapy cycles. We all know that there are several risk factors associated with cardiotoxicity, with several papers in the literature referring that an abnormal baseline global longitudinal strain might flag patients at risk of CTR-CD development, possibly by the detection of subclinical cardiac dysfunction that might get worsened during chemotherapy. The global longitudinal strain threshold value to identify these patients at risk is highly variable, with most of the studies suggesting a value between -18 and 19. However, we should remember that this strain technique has an important intervendor variability that must be considered mainly in this scenario. As I already referred previously, a variation in the global longitudinal strain precedes the left ventricle ejection fraction decline in many myocardial diseases, and also in the cancer therapy-related cardiac dysfunction. And it is also predictive of an anthracycline-based cardiotoxicity 3 to 6 months later after the completion of the chemotherapy cycle. The international literature says that a 10 to 15 relative change in the global longitudinal strain early in the treatment predicted an asymptomatic reduction in the left ventricle ejection fraction and also overt heart failure. And there are also some papers with patients under trastuzumab therapy that refers that the serial GLS assessment has a superior predictive value for future cardiotoxicity compared with changes in left ventricle ejection fraction. And what do the guidelines say about this topic? Well, actually, the last year published guidelines of oncology establishes some general principles for cardiovascular imaging in the evaluation of LV systolic function in these patients. And the authors recommend the utilization of highly reproducible, quantitative volumetric, and non-irradiating methods of imaging as 2D or 3D echo and also CMR. The authors also recommend that for each patient, the same modality and the same facility should be used for serial testing, and that the global longitudinal strain imaging may be considered when available for baseline and serial monitoring of LV systolic function. In the 2016 ESC position paper, a more than 50% relative percentage reduction in the global longitudinal strain is considered clinically significant, and that may indicate the presence of a subclinical LV systolic dysfunction. And the author says that the decision-making concerning the continuation or interruption of chemotherapy should no longer rely solely in a single parameter as the left ventricle ejection fraction, and that the GLS surveillance may become a more sensitive strategy for early detection of cardiotoxicity and to guide the appropriate timing to start cardioprotective therapy in these patients. In addition, in the 2014 expert consensus for multimodality imaging, the author says that although left ventricle ejection fraction is a robust predictor of cardiac outcomes in the general population, it has low sensitivity for the detection of very small changes in the LV function, as most of the times occurs in these cancer therapy therapy-related cardiac dysfunction, and that strain imaging appears therefore as the imaging technique of choice for the detection of this subclinical LV dysfunction. But why should we care about this early diagnosis of cardiotoxicity? Well, first, because once diagnosed, it might change the follow-up program of these patients. By increasing the number of follow-up points with echocardiography during time, and also by indicating the need for a cardiology consultation as referred in these two algorithms published in the 2016 ESC position paper. And also because when we diagnosed this cancer therapy-related cardiac dysfunction, we should think about the initiation of cardioprotective drugs, and we should also consider if it is necessary or not to withhold the cancer therapies. In this algorithm of the last year published oncology guidelines, the authors essentially realized the decision to start cardioprotective therapy and to withhold cancer therapies in the absolute value of the left ventricle ejection fraction. However, the authors also refer that the baseline assessment of the LV ejection fraction may include the global longitudinal strain when it is available. So we need to think about this parameter when we perform echo to these cancer patients. And although it is not the main point of my talk, I think it is important to highlight the importance of cardioprotective drugs in these patients, because the initiation of these drugs most of the times enables to complete the cancer therapy in these patients, because it reduces the risk of overt heart failure and it improves cardiac event-free survival. And the clinical benefit is higher if this medication is started earlier. Actually, the guideline says that even in asymptomatic patients with a normal left ventricle ejection fraction, if we found a decrease in the global longitudinal strain, we should consider the initiation of cardioprotective treatment, and we should reduce the follow-up intervals with echo to evaluate the LV dysfunction. Should reduce these intervals up to 3 months. However, the authors also endorse that life-saving chemotherapy should not be altered solely based on these changes in the LV strain. And to finish my talk, I want to share with you two relatively recently published papers. The older one is this strain-oriented strategy for guiding cardioprotection initiation of breast cancer patients experiencing cardiac dysfunction, published by Santoro et al. In the European Art Journal of Cardiovascular Imaging in 2019. And in this trial, the authors included more than 100 patients with HER2 positive breast cancer submitted to this standard chemotherapy protocol. And from the totality of the patients included in the trial, more than 20% developed CTRCD. All of these patients started cardioprotective therapy with Ramipril and Carvedilol. And from these 27 patients, 4 had criteria for overt CTRCD that was defined by the appearance of symptoms of heart failure and the reduction in the left ventricle ejection fraction to a value below 50%. And all of these patients stopped cancer treatment. And after stopping cancer treatment and with the help of this cardioprotective therapy, only 1 patient fails to recover the LV function to the values previous values that were previous to the starting the drugs. And the remaining 23 patients had a subclinical CTRCD that was defined by a relative reduction in the global longitudinal strain of more than 15%. Most of them in the second part of the chemotherapy protocol under trastuzumab therapy. And all of these patients continued and successfully completed cancer therapy without developing criteria of overt CTRCD. So the main points of this trial was that, as I already said, that global longitudinal strain allows the identification of subclinical CTRCD even when the ejection fraction is still normal. That applying this strategy, the incidence of overt CTRCD was substantially lower than the previously reported in the literature. that patients that developed subclinical CTR-CD were able to complete chemotherapy without interruption, also obtaining an almost complete recovery of the measurements of the LV function as the global longitudinal strain and the ejection fraction, probably thanks to this cardioprotective regimen. And that among the 4 patients that developed subsequent overt CTR-CD, 3 of them could complete the chemotherapy cycle, probably thanks to these cardioprotective drugs. And most important, that with this approach, most of the patients could complete the chemotherapy cycles. But the main limitation of this trial was a lack of a head-to-head comparison between the standard left ventricle ejection fraction versus GLS-based guidance in addressing this cardioprotective therapy. And the recently published SUCUR trial overcame this limitation. The SUCUR trial was published last month in JACC and included more than 300 patients considered high-risk patients because were patients exposed to anthracycline therapy and with at least another risk factor for heart failure. And of these 307 patients were randomly assigned in a one-to-one based to an EF-guided approach that was the usual care arm, where the CTR-CD was defined based on the ejection fraction value and the symptoms of heart failure, and a GLS-guided arm where the CTR-CD was defined based on a relative reduction in the GLS value from the baseline to the follow-up. And when one of these criteria was accomplished, cardioprotective drug with an ACE inhibitor followed by a beta blocker was started. The primary endpoint of the SUCUR trial was the change in the left ventricle ejection fraction from baseline to follow-up, determined by a blinded core lab. The secondary outpoints were the development of cardiotoxicity, and here the definition of cardiotoxicity relies on the reduction in left ventricle ejection fraction as recommended by the guidelines, and also the comparison of the rate of completion of chemotherapy and the rate of heart failure diagnosis in both groups. And here are the main characteristics of the patients included in the SUCUR trial. Most of the patients were patients with breast cancer, some of them with lymphoma or leukemia. The mean left ventricle ejection fraction was around 59%, and the mean global longitudinal strain at baseline was around -20. All of these patients received therapy with anthracycline-based chemotherapy, and most of them received subsequent therapy with trastuzumab. And these are the main results of the SUCUR trial. At 1 year of follow-up, the authors found that the left ventricle ejection fraction was numerically lower in the EF-guided arm compared with the GLS-guided arm. However, this difference didn't achieve a statistically significance. They also found a similar proportion of patients that had a new diagnosis of left ventricle ejection fraction below 55%. There was also a trend toward a worse global longitudinal strain in the EF-guided arm, however, and again, without achieving a statistically significant difference. And the main result of the SUCUR trial was kind of disappointing because the author says that the change in both of these measurements, the left ventricle ejection fraction and the global longitudinal strain between the baseline and the 1 year follow-up was not significantly different between the two arms. But when we look to the CTR-CD criteria, we can see that during the trial, 20 patients in the EF-guided arms had CTR-CD criteria and started cardioprotective therapy with ACE inhibitor and beta blocker, compared to 44 patients in the GLS-guided arm. And this is more than the double of the patients that started cardioprotective therapy in the EF-guided arm. And at the end of the follow-up, considering the CTR-CD criteria defined in the guidelines, we can see that almost 40% of the patients developed CTR-CD in the EF-guided arm versus less than 6% in the GLS-guided arm. And this represents a relative risk reduction of 57% with the number needed to treat of 13 to prevent one CTR-CD event by using the GLS-guided approach to start the cardioprotective therapy. The CTR-CD defined by the global longitudinal strain occurred earlier and more frequently than in the left ventricle ejection fraction group, and this justifies why there were more patients in this group that started cardioprotective therapy, and the hospitalization rates for heart failure in both groups were similar, with one patient being hospitalized in each group. In what concerns to the discontinuation of cancer therapy, it was also quite similar between the two groups, with a numerically higher number of patients that discontinued or interrupted cancer therapy because of left ventricle dysfunction in the GLS-guided arm. But again, this difference didn't achieve the statistical significance. And the SUCCOUR trial was actually a very important trial in this field, because it was the first trial that directly compares a GLS versus an EF-guided approach to start cardioprotective therapy using a randomized design and in a large patient cohort with a multi-center setting. There was no difference between groups in the left ventricle ejection fraction variation from the baseline to the end of follow-up, and this was the main result of the SUCCOUR trial. That was kind of disappointing. However, there was a reduction in the incidence of the CTR-CD with the GLS-guided approach in the starting of cardioprotection, and a better preservation of left ventricle ejection fraction was also identified. There were more patients that started cardioprotective drugs in the GLS arm, with no differences in the cancer treatment interruption. So back into the beginning, where are we with the strain imaging in cancer patients nowadays? Well, actually, we are still in a gray zone. And my final messages are that although left ventricle ejection fraction is the most commonly used parameter for identifying LV dysfunction associated with cancer treatments, when a reduction in left ventricle ejection fraction occurs, it may be too late for starting cardioprotective treatment that allows a complete recovery and to complete chemotherapy in these patients. And this is where the global longitudinal strain has emerged as an early marker of cardiotoxicity to improve risk prediction and stratification in order to establish a closer monitoring and with the potential to guide cardioprotective therapy initiation in these patients. However, the SUCCOUR trial recently published challenges a little this last point, and consequently, larger prospective studies are needed to determine the exact value of GLS to guide the initiation of cardioprotective therapy, and also to standardize the most optimal diagnostic thresholds for CTR-CD or for identifying patients at risk of CTR-CD. And my very final message is a message of hope, because cardiotoxicity detection with cardiovascular imaging is definitely a growing field, with several tools that are being developed and improved, from the development of the global longitudinal strain technique, the 3D echo, and also the evaluation of strain using tissue tagging in CMR, and the myocardial characterization with the mapping technology using CMR. And thank you very much for your attention.
Thank you, Joanna, for your very good presentation. Is there any questions from the audience?
Yes, I do have a couple of questions, Professor, if I may. So we've been looking at strain for quite some time now, and we always talk of strain as if it was a very new, innovative thing, but in reality, it's been with us for quite some time now, and we're still not completely sure about what to do with it. And this is another example of those cases. So my question to Dr. Rigueira is essentially, how does she see the SUCCOUR trial? Because some people are going to look at the main headline and think of it as a fundamentally negative trial, which would essentially almost kill off strain in the setting of cardio-oncology, while others will probably look at more finer details and find still some usefulness of strain in this particular setting. I tend to align mostly with the second group, actually, despite all the limitations of it. I'd like to know what she thinks about it.
Thank you very much, Dr. Naber for your question. So I definitely agree with you. And although the JAC editorial of the paper was quite destructive, looking just to the main endpoint of the trial, I think that the SUCUR trial definitely not closes the door for strain imaging evaluation, but actually opens a window for future studies. Actually, because I think it is important to highlight that the SUCUR trial was the first randomized trial that compared directly the GLS evaluation with the left ventricle ejection fraction, and evaluated left ventricle ejection fraction using 3D echo that is not common in the other trials. And I think those are the most positive points of the SUCUR trial. It is important to look between the lines when we look to the SUCUR results, because the authors actually justifies the absence of difference in the left ventricle ejection fraction in the end of follow-up, because they evaluate all the patients, the one that developed CTRCD and the patients that didn't develop CTRCD, that were most of the patients. And actually in those patients, there were a slightly increase in the left ventricle ejection fraction that might justify this absence of difference between the two groups. And when the authors looked just to the patients that developed CTRCD, actually they found differences, as they say in the results, and as I already said in my talk, because they found a difference in a reduction in the left ventricle ejection fraction of almost 9% in the patients evaluated with left ventricle ejection fraction, compared to 2% in patients in the GLS arm. But again, in the GLS arm, more than a double of the patients compared with the left ventricle ejection fraction arm started cardioprotective treatment, and this also might have influenced the results. So I definitely think that the SUCUR trial is an indicator that we need more studies to determine exactly what is the paper or what's the role of strain imaging to guide the initiation of cardioprotective treatment.
Thank you. That was very clear. And what do you think are the main practical limitations? What I mean is, why do you think that, aside from the scientific limitations, but from a practical standpoint, as an operator who uses strain frequently, what do you think are the main practical limitations that make strain such an underused technique? So why is it that we don't do strain as commonly as we do ejection fraction, for example?
I think that the main limitation of strain imaging is that if you want a very accurate strain value, you need a very good acoustic window. And in the real practice, that sometimes not happen. And actually we have other limitations, as we also have in left ventricle ejection fraction, as the load conditions of the patients, with the variation in the blood pressure and so on, that might affect the evaluation of strain imaging.
Thank you.
For me, the SUCUR trial was really very disappointed. But anyway, we're not prepared to get rid of the strain. On the contrary, and we have several patients that have a decrease in GLS, but a normal ejection fraction. Usually, what we do is just monitorize the patients, and we don't advise to suspend the cancer therapy. I think it's consensual. But anyway, because we know from the SUCUR trial that they stopped the cancer therapy. That's one of the criticism of the editorial, and we understand it very well. What would you advise? Do you advise to seek another imaging technique to do to these patients in this case?
Well, yes, actually, in the Sukur trial, they actually stopped the cancer therapy based just in the GLS assessment that was not recommended by the guidelines. So I think that in that conditions, when we think to suspend cancer therapies that might save the patient's life, we should be very careful with our decision. And definitely we should, if it's just the global longitudinal strain, or even just left ventricle ejection fraction, because as so many limitations, we should not rely our decision only in one parameter. And in my opinion, I think that we should think about other cardiovascular imaging techniques as CMR and the evidence of myocardial fibrosis, the evidence of the presence of late gadolinium enhancement, and also the abnormal values in the mapping technology of CMR that might have a role and help us with this decision, and obviously probably including also biomarkers and so on, because I think that we should consider several parameters to make that decision.
I agree completely. Yeah. I think we don't have more questions here in the chat. Okay, then thank you very much, Joanna. It was a pleasure. It was a very good presentation. Thank you very much.
Thank you very much.
Good afternoon, dear colleagues. Thank you for this kind invitation. It is a great pleasure to be here and to be part of this postgraduate course of cardio-oncology. It's also a great pleasure to introduce my colleague, Dr. João Agostinho. Dr. João Agostinho is a cardiologist and also an heart failure expert from Santa Maria University Hospital. And we'll talk about antifailure cancer and revealing the link. Thank you, Dr. João Agostinho. The floor is yours.
Hello, good afternoon. And so I will talk about heart failure and cancer and their relationship. So I'll try to unravel the link between those two pathologies. So heart failure and cancer are two major causes of morbidity and mortality, and their prevalence may grow as the age of the population and the burden of common risk factors increases. And in the last years, the main focus of cardio-oncology was the prevention and treatment of cardiovascular disease and in cancer patients or cancer survivals. Because we know for sure that heart failure develops as a result of cardiotoxicity and sometimes as a result of common or the burden of cardiovascular risk factors that the patients with cancer have. And considering this, we had the position paper published by the cardio-oncology group of the EAC that focused on cancer treatments and cardiovascular toxicity. Of course, the relationship between cancer therapy and heart failure is well known, mainly with anthracyclines, also checkpoint inhibitors, also trastuzumab. Those effects are very well studied. The same for radiotherapy, and in some kinds of tumors, like plasma cell malignancies, there is a direct
Sim, sim, não, parece para onde eu estava à espera, mas eu estava a ter isto bem, mas onde é que se horrível? Agora já está a falar com ele em ouvido, de certeza.
Expression of serotonin and development of carcinoid syndrome. This is well established, and also we know that heart failure per se is one of the main risk factors for the development of cardiotoxicity. So this relationship is well established. However, the co-occurrence of cancer and heart failure is also a major clinical problem, and this problem has severe impact on both diseases as each pathology impinges the treatment of the other one. And actually, one data is very concerning is that the fact that cancer is the main non-cardiovascular cause of death in heart failure patients. Either we use data from the paradigm HF, TOPCAT or iPreserve, two relatively recent clinical trials in heart failure. We can see that cancer was actually that main reason of non-cardiovascular death. And so we consider that heart failure may be a cancer predisposing condition. Why is that cancer is the main non-cardiovascular cause for death in patients with heart failure? In fact, patients with heart failure, when we compare a cohort of patients with heart failure with matched controls, the development of cancer is higher in the group of patients with heart failure, independently of the age, as we can see in this data from the Danish National Registry. Some people postulated that this may be related to more intense follow-up of heart failure patients compared with healthy controls. But in fact, if we do not take account for the cancers diagnosed in the first year of follow-up, actually these difference keeps to be statistically significant. So this in fact of more follow-up, more strict follow-up actually seems to not have any relationship with the cancer diagnosis. In fact, in this other study, patients with myocardial infarction were followed up and the population was separated in patients that developed heart failure and patients who did not develop heart failure in the follow-up. And actually the incidence of cancer was higher in patients with heart failure. So this also suggests that heart failure per se is a predisposing condition, not just the presence of cardiovascular disease. And this led to the more recent thought that despite heart failure is actually a common complication of cancer treatment, heart failure seems actually to be a cancer predisposing condition, and also heart failure and cancer share some common risk factors that can lead to both diseases at the same time. So considering this, there's this new theory that those risk factors actually lead to the development of both diseases, and they strengthen a common perturbed milieu of inflammation and oxidative stress that perpetuates and leads to the development of cancer and heart failure. And also heart failure, in fact, due to secreted factors and the activation of the sympathetic nervous system and the RAS system may lead individually to cancer development. So talking about those common risk factors, actually hypertension is a prevalent and well-established risk factor for heart failure. Actually, every 10 millimeters of mercury increments on blood pressure was related to the development of cancer. Small yet significant association between hypertension and cancer may be suspected when considering these higher risk for the development of cancer. And in fact, the EGF may play a role on this mechanism. Regarding obesity, the risk of developing heart failure is higher in obese patients. But actually, when a patient develops heart failure and is obese, he has a survival advantage regarding death due to heart failure. When considering cancer, actually obesity is responsible for 20% of the incidence of cancer worldwide. And these effects in heart failure and in cancer may be due to a state of chronic and low-level inflammation, which may lead to DNA damage. Considering diabetes, as is well known, patients with diabetes have high risk of developing heart failure, and patients with heart failure also have a higher risk to develop diabetes. There is this vicious cycle relation between heart failure and diabetes. Inflammation-related markers partially explain this strong relationship between both pathologies. Regarding cancer, the presence of diabetes is also associated with an increased incidence of cancer. And the proposed mechanisms are increased inflammation, increased oxidative stress, and direct effects of excess glucose and insulin signaling. Regarding diabetes therapy, may also be a relationship with the development of cancer and insulin therapy due to an elevation of the insulin growth factor. And actually, metformin seems to be associated with a lower incidence of cancer in diabetic patients, as we can see in this meta-analysis. Smoking is a well-known risk factor for both heart failure and cancer, and actually persistent smokers have a higher risk of developing cancer compared to those that stop smoking. And actually, I won't take much time talking about smoking because it is well-known risk factor for both pathologies. Dyslipidemia is also an important risk factor for the development of ischemic heart disease and consequently heart failure. Regarding cancer, we know that 27-hydroxycholesterol, a metabolite of cholesterol, have been implicated in breast estrogen receptor positive cancer progression. So this is also a shared risk factor between two pathologies. Regarding lifestyle, healthy behaviors such as smoking cessation, increased physical activity, weight loss, healthy diet, and reductions of cholesterol and blood pressure, and adequate blood sugar control were shown to facilitate a lower incidence of cardiovascular disease and also a lower incidence of cancer. Actually, patients who met these targets, all these targets, had a 51% lower risk to develop cancer. And the last common risk factor I will talk about is the genetic traits that can lead to heart failure and cancer. Both cardiovascular disease and cancer have numerous genetic risk factors, but the number of genetic risks that are common risk factors for the two pathologies is not that high. Actually, I would talk about WNT-B-catenin pathway. Those mutations may be involved in coronary artery disease and also in some kinds of cancer. And the gain of function of DERK1B gene mutations leads to cardiovascular disease. And at the same time, this gene is overexpressed in many tumors, and there may be a relationship here between the two pathologies. I will give more importance to clonal hematopoiesis of indeterminate potential, also known as CHIP. Actually, CHIP develops through life as age increases. And those clonal hematopoiesis actually can be measured, and they are a common risk factor for the development of mainly hematological malignancies, but cardiovascular disease, accelerated atherosclerosis, thrombosis, and also heart failure. The mechanism is not well known, but it seems to be related with the development of ischemic cardiac disease. And this is a new field of investigation regarding heart failure development and treatment. Talking about the common perturbed milieu between heart failure and cancer, this is maintained by a chronic state of inflammation and oxidative stress. the link between heart failure and cancer is apparent in the recently published CANTOS trial with canakinumab that reduced lung cancer incidence and lung cancer mortality at the same time that reduced cardiovascular events. And so this trial actually proves that maybe this relationship between inflammation and heart failure and cancer development. Actually, this is also important due to the fact that pro-inflammatory and pro-cancerous factors are elevated in heart failure, as TNF-alpha, interleukin-1, and interleukin-6. This is very evident in this study I brought here. This is a study with mice. Actually, those mice, there was a control group of mice that are predisposed to the development of colon cancer, and a group that was in which there was produced an acute myocardial infarction. And actually, this study group had higher levels of interleukins. Those groups of mice were then compared regarding development of colon cancer, and actually it was higher. The tumor size, the tumor count was higher in the group of mice that had acute myocardial infarction. In the same groups, or using the same mice, heart failure hearts were transplanted heterotropically. So the mice were kept with the same hemodynamic conditions, with their normally functioning heart in place, but heart failure heart was transplanted in some of them. And actually, also in those mice, interleukin levels were higher, and actually tumor growth was higher. And this proves that heart failure can lead to cancer, and it is not only dependent on hemodynamics, also in the presence of a failing heart in the system. Oxidative stress also plays an important role in both diseases. Actually, heart relies on mitochondrial oxidative phosphorylation, which plays an essential role in cancer progression, and this is, or this may be a link between the two diseases. And also, increased glucose occurs in heart failure, and glucose oxidation is impaired, and oxidative stress actually is higher in heart failure, which may lead to cancer development. Besides those pro-inflammatory factors released or related to heart failure, the heart may seem to secrete some other factors that can lead to tumorigenesis, like serpin-A3, that is a recently discovered example. Also, NT-proBNP may be just a marker of heart failure severity, as we know it, or a causative factor for distant tumor growth. Actually, when we compare the incidence of cancer regarding the terciles of NT-proBNP, the incidence of cancer is higher in the higher tercile of NT-proBNP. And actually, several tumor cells express natriuretic peptide receptor A, that is a receptor for BNP and ENP. And the genetic collection of natriuretic peptide receptor A attenuated tumor growth and neuroangiogenesis. On the other side, ANP may seem to inhibit extraction of malignant cells. So this is a matter of discussion, and actually we don't have a right answer regarding NT-proBNP, BNP, and ENP role in cancer development. And also cancer can development as a consequence of neurohormonal activation due to heart failure. Regarding the sympathetic nervous system activation, it is clearly stated that the two main pathways, sympathetic nervous system activation will lead to the inhibition of apoptosis, impaired DNA repair, and gene expression that will lead to the development of cancer. And also it produces lots of factors that will lead to neoangiogenesis, invasion, and lymphoangiogenesis, migration, that will lead to metastasization. Also, the activation of the sympathetic nervous system will lead to decrease NK lymphocytes function. So there is an impaired immunosurveillance, and also it will lead to protection against anoikis, that is a kind of apoptosis that occurs when the cancer cells are detached from the cancer mass or the cancer matrix, and this also leads to distant metastasization. Regarding renin-angiotensin-aldosterone system activation, it seems that angiotensin II has a role on angiogenesis in tumors and also in tumor metastasization, mainly due to interleukin 6 and VEGF production. Aldosterone may also be related to tumor dissemination. This is not entirely proven, but there may be a relation between those two pathways. And so, to conclude, and as we talked about the mechanisms in heart failure leading to cancer, does heart failure medications have any effect on cancer? Actually, with diuretics, there is no clear suspicion of cancer risk, only with hydrocortisone and skin cancer due to higher sensitivity of the skin to light. Regarding ACE inhibitors and ERBs, some observational studies suggested a favorable cancer outcome, but meta-analysis and trials had inconsistent results, so we actually don't know. Same happens with beta blockers, where there is an unclear impact on cancer outcomes, but actually there may be a bias here when we analyze these facts, because as heart failure medications are aimed to reduce cardiovascular mortality, cancer-related mortality might seemingly increase, and so it's difficult to prove the real effects of heart failure medications in cancer incidence and prognosis. So, for the last years, the main focus of cardio-oncology has been the prevention and treatment of the effects of chemotherapeutic agents on heart failure. But cancer is a frequent comorbidity in patients with heart failure. And this may suggest that pathophysiological connection exists between the two. Shared risk factors and circulating factors directly link both diseases, and also pathological mechanisms may explain the interactions, but actually this relationship is very complex and not entirely proven. So comprehensive and detailed studies will be needed to elucidate the connection between cardiovascular disease in general, heart failure, and cancer. Thank you.
João, thank you. It was excellent. Thank you for your excellent talk. Very interesting, these new links between heart failure and cancer, far beyond the classic cardiotoxicity and heart failure. I have a question for you about a clinical question. In this high-risk population, and in our daily practice, that is a window of opportunity, what are the red flags or clues that we should be aware to detect early cancer in these patients and fellow patients?
Hello. First of all, I would like to thank the organization for the invitation to be present, and also thank Dorothea for the excellent question, a practical question in a not so practical thematica. So I actually think that we should stick to clinical evaluation and blood tests mainly to do this. In fact, I think it really depends on the kind of follow-up these patients have, and I would insist that the more important thing regarding identification of cancer and any other comorbidity in heart failure is based on regular and protocolized follow-up. So I think that if we keep to what is recommended in the ESC heart failure guidelines regarding follow-up, so a strict follow-up in an heart failure clinic with routine blood tests, I would just recommend the blood tests explicited in the heart failure guidelines that are pretty complete, with liver blood tests, kidney function, ferritin, iron, complete blood count, and also throughout clinical evaluation, mainly with attention to constitutive symptoms. And I will talk a little bit more about this kind of symptoms in a bit. I think that if we do that, and if we follow our patients regularly, we will be able to identify all the incidence of new cancer in a patient. The main problem here is that heart failure per se, mainly in an advanced phase, also leads to constitutive symptoms, cachexia, anorexia, and other symptoms like that. Also in heart failure, there are a lot of weight variations during the follow-up. So I think it is still a little bit difficult to differentiate what may be related to heart failure progression and what may be related to a new diagnosis of cancer. I would suggest to lower the thresholds to do specific tests looking for cancer, like colonoscopy, endoscopy, pulmonary CT scan, as lung cancer is very common in heart failure patients. When these kind of symptoms start to appear in any patient, but I would recommend just keeping regular follow-up in heart failure patients, and throughout follow-up with clinical complete evaluation and routine blood tests as recommended in the heart failure ESC guidelines. And I think with this, we won't miss that much new diagnosis of cancer.
Yeah, I agree with you. I think you agree with me if I say that absolute ferropenia is frequent in these patients, and we repeatedly assess the ferric profile. Is crucial to start a screening for gastrointestinal cancer, or to refer this patient to the family physician to start a screening about gastrointestinal cancer that is very frequent, the most frequent. Thank you, João. I think we can ask questions to the audience, the virtual audience. Professor Manuela Fiuza.
Well, talking about the reverse cardio-oncology, continuing this aspect, atrial fibrillation can be seen also as a marker of occult cancer, right? There is a relationship between the new onset of atrial fibrillation and the appearance of cancer in the first, let's say, 3 months after the AF appearance. And should we screen these patients for cancer? Those patients with the new onset atrial fibrillation? It's a question.
Actually, I think the answer for that question, that is a very good question, is very similar to the one I answered before. I don't think we should do systematic CTs or systematic colonoscopies just because atrial fibrillation appeared. I think we should do, actually, atrial fibrillation is also a marker of disease or the compensation of any other disease. So as Professor Manuela said, it can be a marker of a new diagnosis of cancer. So I think a complete clinical evaluation with routine blood tests may be enough to detect other alterations that can suggest a new cancer diagnosis, and guided by those alterations, those blood test alterations, those new symptoms associated with atrial fibrillation appearance, I think we can select the appropriate exams to continue the investigation. I think it should be individualized always.
Sure, I was thinking about cancer biomarkers.
The main problem about cancer biomarkers is that, well, it's not that frequent regarding atrial fibrillation, but actually in heart failure, they are actually in the general population, they are not that specific. And concerning heart failure, not atrial fibrillation, concerning heart failure, they have even lower specificity because lots of those cancer biomarkers are markers of serosities. And the higher volume that patients with heart failure have, congestion, may be a reason to detect elevations of those kind of biomarkers. Yeah. So I don't recommend the routine use, but the personalized use of that kind of markers.
And I have another question.
Yes, Manuela?
Okay, we know that the ACE inhibitors are mandatory in heart failure, of course, but they have the potential negative effects of stimulating neoplastic growth and angiogenesis. So sartans are preferable? For instance, is sacubitril valsartan is useful in these cancer patients with heart failure?
I think sacubitril valsartan is useful in almost every patient with heart failure and reduced ejection fraction. The main thing is that we don't really know about the mechanism of natriuretic peptides and its relation with cancer. As I said in the presentation, there are natriuretic peptide receptors in lots of tumors, and so there may be maybe they are related to tumor growth, but in fact, I would suggest that not using them, or I would say that not using this kind of medication in heart failure will lead to even worse prognosis. So I don't think we should impinge on heart failure treatment just because the patient had cancer. And the contrary is also true. So I think we should promote and keep on if heart failure medications, the better we know, and also in cancer medications, the better we can do in these patients, so that both pathologies are optimized. The data we have as for now is not conclusive. There are some trials or meta-analysis that should suggest the problem with ACE inhibitors. Other meta-analysis suggests they are even beneficial. So we don't really know. The same is true for sacubitril valsartan. I would suggest to keep strict to the guidelines in this case and keep using these medications, because in fact, in the other way around, sacubitril valsartan is, as we start to see in new trials, new observational studies, is very useful in patients that develop heart failure due to cardiotoxicity. So I don't think we should preclude the use of those kind of medications in patients with heart failure that develop cancer.
Okay, thank you.
Any data from the new SGLT2 inhibitors, João?
Actually, there is a small study that shows a neutral effect on cancer incidence, but I think it's not enough to prove if they are beneficial or not in the incidence of cancer. I think here SGL inhibitors may have a role because they treat diabetes, that is a common risk factor. They reduce oxidative stress, and that's a main driver for the development of cancer in heart failure patients. Actually, I believe that one of the mechanisms through which the SGLT2 inhibitors work in heart failure is by the reduction of glycolysis-dependent metabolism and the increase of ketone metabolism. And that's a kind of metabolism that it's like when we compare an electric car with a combustion car. It's a more clean kind of metabolism. It leads to less production of ROS. So it leads to less oxidative stress. And I think that countering that mechanism, we could reduce at least inflammation, at least oxidative stress, and maybe cancer incidence in heart failure patients. It's just a theory in which I believe, yeah, but I think we'll have some news in the next years.
Okay, thank you. I have Dr. Miguel Nobre Menezes have a question. Please, Miguel.
Thank you. Thank you. So it's a bit of as a follow-up of everything you just said. You've partially answered, but so because I have two renowned heart failure experts standing in front of my screen, and because very frequently in the setting of cardio-oncology, what we have is just a mid-range heart failure presentation or preserved ejection fraction presentations of heart failure, sometimes without heart failure per se, but just mild decreases of ejection fraction. And because there's currently no specific evidence about which drugs to use, you as heart failure specialist, if you had to choose one particular class that you think would very nicely suit these kinds of patients, what would that be? Would you prefer ARNIs? Would you prefer SGLT2 inhibitors, or the good old beta blockers, ACE inhibitors, and so forth? And I'm asking this in light of the evidence that's slowly been arising about SGLT2 inhibitors, and also about the fact that the sacubitril valsartan narrowly missed the endpoint in preserved ejection fraction trials. So it's a very opinion question.
Yes.
Obviously, there's no evidence.
I can answer
experience-based.
very quickly. In line with the last results, I will choose the iron use, sacubitril valsartan, and beta blocker, with no doubts. For the game.
Yeah, I agree. Actually, the Americans have just approved sacubitril valsartan to use in heart failure with
mid-range
ejection fraction, yes, until 60%, I think. So it's actually using a sub-analysis of a trial. It's not that correct, but I also believe that the sacubitril valsartan may be a good option, even in the absence of heart failure. We actually did an analysis because we had a small group of patients in our heart failure clinic in which we started sacubitril valsartan with low levels of NT-proBNP. And actually, those patients had better prognosis than the matched patients by age, ejection fraction. I think we had 27 patients compared to 54, and we have no mortality in the group of patients with low NT-proBNP in which we started sacubitril valsartan. Actually, it's an off-label use of sacubitril valsartan in patients with not that high NT-proBNP and very, very mild or even no symptoms of heart failure, but actually those patients also benefit from that. So I would think, say that I agree with Dorothea.
There is already evidence. Yes.
Yeah.
So it's consensual, because that's also the experience we've been having in cardio-oncology. Very good experience with sacubitril valsartan, even in the absence of heart failure, in those patients who just drop a few points on the LVF.
Yes. Thank you, Miguel. Okay. Another time, thank you, Dr. João Agostinho and Professor Manuela Fiuza for the opportunity. I think we close the section and see you next year. Thank you.
Thank you.
Hello, everybody. We will have a change in our program. So it's my great pleasure to introduce to you all Dr. Michael Fredley. He is a cardiologist and associate professor at Penn Medicine, and currently is the medical director of the CardioOncology Center of Excellence in that institution. He is also an electrophysiologist, so I think he's the best person to give this talk. CardioOncology, the electrophysiologist's perspective. Welcome, Dr. Michael Fredley.
I want to thank the organizers for inviting me to participate in this fantastic meeting. I'm both a cardio-oncologist and an electrophysiologist, and I think you'll see that EP issues are a significant problem in cancer patients, and we have many more questions than answers, and treatment really requires a nuanced and collaborative approach to care. These are my disclosures. So objectives for this talk. First off, I want to review the current state of knowledge of cancer treatment-associated arrhythmias, discuss some novel data regarding arrhythmia management in cancer patients, and then highlight challenges in rhythm and anticoagulation management in cancer patients. So I wanted to start off by briefly mentioning some recent data on cancer treatments associated with arrhythmias. And we'll start off with the BTK inhibitor ibrutinib, which is a small molecule inhibitor of the Bruton's tyrosine kinase and is used in the treatment of various B-cell malignancies, including CLL or chronic lymphocytic leukemia. You probably know that ibrutinib is associated with the development of atrial fibrillation with rates up to 15%. And in this systematic review and meta-analysis, the pooled rate of ibrutinib-associated atrial fibrillation was 3.3 per 100 person years, compared to 0.86 per 100 person years for the non-ibrutinib regimens, with a relative risk of ibrutinib-associated atrial fibrillation of 3.86. Now, beyond just atrial arrhythmias, there's also an increased risk of ventricular arrhythmias with ibrutinib. In the original FAERS data, which is the United States FDA adverse reporting system, there was 13 cases of ventricular arrhythmias with 6 episodes of sudden death. And then a follow-up study amongst 582 ibrutinib-treated patients showed that the incidence of ventricular arrhythmias was 596 per 100,000 person years. Now, there's emerging evidence into the mechanism of ibrutinib-associated arrhythmias. Arrhythmias are not due to QT interval prolongation, and in fact, our group recently demonstrated that QT interval shortening occurs with ibrutinib. And so with this in mind, Zhang and colleagues demonstrated that abnormal calcium handling in ibrutinib-treated myocytes can lead to a significant decrease in the amplitude of calcium release. And then most recently, David Mylan's group at the Massachusetts General Hospital reported that off-target C-terminal SERC kinase inhibition may be responsible for ibrutinib's arrhythmic potential. And it is because of this that we may actually explain why other BTK inhibitors don't cause arrhythmia, because acalabrutinib and zanubrutinib don't seem to have that same off-target effect on the C-terminal SERC kinase. Now, moving on to immunotherapy and the immune checkpoint inhibitors, we know that both tachy and brady arrhythmias are common initial manifestations of immune checkpoint inhibitor myocarditis, as seen in this original report from the New England Journal of Medicine. And then in this study from JACC CardioOncology, arrhythmias and heart failures clearly dominate the adverse cardiac events associated with immune checkpoint inhibitors. And then from the data on the right, atrial fibrillation is the most commonly observed arrhythmia, though ventricular arrhythmias and conduction abnormalities occur with significant frequency. Now, beyond the checkpoint inhibitors, there are many novel immunotherapies that are currently under development. And one that is really gaining a lot of interest is CAR T therapy, or chimeric antigen receptor T cells. And they really are being increasingly utilized for various cancers. Now, for those of you who are not familiar with this, T cells from patients are genetically altered to express CARs, which are artificial proteins consisting of both antigen recognition and T cell signaling domains, allowing them to attack cancer cells that express that target antigen. Now, in our study of 137 CAR T recipients, 12% experienced a cardiovascular event defined as an arrhythmia, decompensated heart failure, or death, with atrial fibrillation being the most frequently identified arrhythmia. And in another study from the University of Pennsylvania, 21% of patients experienced a major adverse cardiac event, many of which were arrhythmias. And these arrhythmia events are thought to be directly related to the cytokine release syndrome associated with the CAR-T infusions. Now, arrhythmias are also a risk for patients with chemotherapy-induced cardiomyopathies. And we do have some data specifically evaluating that population, especially those that have developed anthracycline-induced cardiomyopathy. And the burden of arrhythmias appears to be similar amongst those patients with a chemotherapy-induced cardiomyopathy when compared to those patients who had other forms of non-ischemic cardiomyopathy, with atrial fibrillation being the most commonly identified when looking at implantable device information. Moreover, data from Dr. Herman's group at the Mayo Clinic showed that overall survival was not significantly different in the chemotherapy-induced cardiomyopathy group compared to other cardiomyopathy etiologies, both ischemic and non-ischemic. What we don't really know is how to best monitor for arrhythmias in cancer patients. And I think it's an opportunity to leverage our developing technology from wearables like the Apple Watch to implantable monitors to better understand this phenomenon. And I think that we should all be thinking about ways to use these devices and their associated data to better understand arrhythmias. And I think that you'll start seeing quite a few studies coming out that are really focusing on these novel technologies to better evaluate cancer-associated arrhythmias. So what about the management of atrial fibrillation in cancer patients? Atrial fibrillation is clearly the most common arrhythmia that we see in this population, and it really does require a very specialized approach to its treatment. So when thinking about rate versus rhythm control, we generally follow the same algorithms for cancer patients as we do for the general population, though cancer-specific algorithms are likely necessary and I think would be very beneficial to provide optimal care to our patients. Now, in cancer patients, it is especially important to screen for potential drug-drug interactions, especially those impacting the metabolism of cytochrome P450, 3A4, and 2D6, as well as the P-glycoprotein system. Now, for asymptomatic individuals with atrial fibrillation, a rate control strategy is appropriate. A goal resting heart rate of less than 110 beats per minute is reasonable. However, it's important to remember that baseline hypotension may limit the implementation of an adequate rate control strategy in many cancer patients. Now, rhythm control is preferred for patients with symptomatic atrial fibrillation or for those with heart failure felt to be worsened by atrial fibrillation. The recently published EAST-AFNet-4 trial demonstrated that an early rhythm control strategy may be helpful in preventing the primary composite outcome of death from any cardiovascular cause, stroke, or hospitalization with worsening of heart failure or acute coronary syndromes, even in the absence of symptoms. However, it's important to remember that in this study, as is the case with most electrophysiology studies, the benefits of this approach in cancer patients has not been established. Now, one rhythm control strategy is DC cardioversion. That's really, oftentimes our first initial attempt at rhythm control. And although it is initially successful in most patients, long-term durability is questionable given the inflammatory milieu of cancer, along with the continued use of provocative cancer therapeutics. And studies directly evaluating the efficacy in cancer patients is lacking. We do have one study that looks at the benefits and the success of DC cardioversion in the amyloid population. And of the 58 amyloid patients that were evaluated, half of them had AL amyloid, so the malignant type of amyloid. And they compared it to 114 matched control patients. And they showed that cardioversion success rate and arrhythmia recurrence rate was not significant between the amyloid group versus the control group. That being said, Amyloid patients had a higher procedural cancellation rate and procedural complications. And so I think this is an opportunity for us to broaden this evaluation and look at procedural success and recurrence rates in the general cancer population, looking at various different cancer subtypes and associated therapies. Now, antiarrhythmic medications have not been specifically studied in the cancer population either, and we have to be very mindful of the potential for drug-drug interactions leading to QT interval prolongation. And interactions with the cytochrome P450, 3A4, and 2D6 systems, as well as the P-glycoprotein system, can affect drug metabolism. In general, dronedarone should be avoided due to its effects on both CYP3A4 and the P-glycoprotein systems. And although amiodarone is frequently chosen to treat cancer-associated arrhythmias, given its relative ease of use in this population, especially since many of them often have underlying cardiovascular disorders, it can also increase various cancer drug concentrations due to its effects on these same pathways. Now, in addition to drug-drug interactions, certain antiarrhythmics may not be an option due to patients' underlying cardiovascular or oncologic diseases, such as those patients who have coronary disease or those patients that have left ventricular hypertrophy from amyloidosis. And of course, the question always comes up about catheter ablation. Now, this is the only study to date looking specifically at safety, and it showed that in cancer patients, the peri-procedural risk of clinically relevant bleeding was more frequent in patients with cancer than in those without cancer. So bleeding is more common if patients had cancer, not entirely surprising. We have no data, however, specifically evaluating the efficacy of catheter ablation in these patients. And given the potentially different pathophysiology, for example, the fact that ibrutinib is likely to cause atrial fibrillation through its off-target effects on intracellular signaling pathways, it's an important area to further investigate and determine whether our traditional approach of pulmonary vein isolation is actually effective. Now, I want to touch base on thromboembolism prophylaxis in the setting of cancer patients with atrial fibrillation. Now, the mainstay of thromboembolism prophylaxis is anticoagulation, and the current agents include low molecular weight heparin, which is often preferred in cancer patients because of the DVT literature, though its efficacy in preventing AFib-associated thrombosis is not established. We have warfarin, which is obviously challenging in cancer patients, and then the DOACs, dabigatran, rivaroxaban, apixaban, and edoxaban. The DOACs are now the preferred anticoagulant for stroke prophylaxis in non-valvular atrial fibrillation, and they're being increasingly utilized in cancer patients based on encouraging data, particularly as it relates to deep venous thrombosis. But there is actually some data to support their use in cancer patients with atrial fibrillation as well. So this is a market scan database study looking at more than 16,000 active cancer patients who are initiating anticoagulation for atrial fibrillation. Rates of bleeding were lower with apixaban and similar with dabigatran and rivaroxaban when compared to warfarin. And ischemic stroke rates did not differ among the different anticoagulants, and incident VTE was lower with DOACs. So DOACs really seem to have a role in this population. Now, despite their general safety and efficacy, many cancer patients may not be getting appropriate guideline-directed anticoagulant therapy. And in our study that was recently published in JACC CardioOncology, 296 patients with a CHA2DS2-VASc score of 2 or higher, so high stroke risk, and a HAS-BLED score of less than 3, so low bleeding risk. 44.3% of those patients did not receive anticoagulation. And then if you look in that cohort, only 18% had platelet values of less than 50,000. And then in multivariable analysis, older age, hypertension, prior stroke, and a history of venous thromboembolism were each directly associated with anticoagulation use, while current chemotherapy use prior bleeding, renal disease, and thrombocytopenia were each inversely associated with anticoagulation use. And so I think this study really highlights the need to improve the application of standard atrial fibrillation treatment algorithms to the cancer population. Now, nevertheless, the CHA2DS2-VASc score may not actually be the ideal algorithm to assess for stroke risk in cancer patients. This was a study from Denmark, and patients with recent cancer were at a higher risk of bleeding irrespective of their CHA2DS2-VASc score. Moreover, cancer patients were also at a higher risk of thromboembolism with a CHA2DS2-VASc score of 1, but a lower risk of CHA2DS2-VASc score when a CHA2DS2-VASc score was greater than 2. So they were at higher risk at the low CHA2DS2-VASc scores and lower risk at the higher CHA2DS2-VASc scores. This is obviously surprising data. Now, a potential explanation includes an underestimation of the risk of thromboembolism due to the competing risk of death in cancer patients with higher CHA2DS2-VASc scores, biasing the results towards the null. Regardless of the interpretation and risk stratification based on CHA2DS2-VASc scores in atrial fibrillation in cancer, this should be done with caution. And it is essential that cancer-specific risk prediction algorithms be developed to guide our decision-making regarding anticoagulation in the setting of AFib and flutter, balanced by the potential risk for bleeding. And finally, is there a role for the use of left atrial appendage closure devices? Well, again, no studies to date specifically evaluate this technology in cancer patients. However, I think we should be looking into it in cancer patients. It is also important to remember, however, that as of now, short-term anticoagulation is still necessary, and the risk of device-related thrombus could potentially be increased in the hypercoagulable state of cancer patients. And for the last section of the talk, I just want to briefly touch on what we know about cardiac implantable electronic devices in cancer patients. I'm not going to go into any details about management of devices in the setting of radiation therapy, because that really could be a talk into of itself. But I do want to at least talk about what we know regarding the benefits and the utilization of pacemakers and defibrillators in cancer patients with arrhythmias. So this was a study, a Danish study, of 5,600 patients with implantable defibrillators, and 5.1% of them had a pre-existing diagnosis of cancer, with more than half having had a hospitalization for their cancer in the 3 months prior to ICD implantation, suggesting that this was a group of patients with ongoing or active disease. The majority of the patients had male GU cancers, so prostate cancer, not surprising, older male population, often a lot of associated cardiovascular disease. And patients with very poor prognoses, like pancreatic cancers, had low representation. Now, amongst those patients that were receiving primary prevention ICDs, there was no significant difference in mortality among those with or without cancer. In the secondary prevention group, however, cancer was associated with a significantly higher 1-year and all-time mortality. Now, given this higher mortality, one may be tempted to state stricter patient selection is warranted with regards to secondary prevention. However, when you start to dig into the data a little bit deeper, it's important to note that amongst the cancer patients that were getting a secondary prevention ICD, 2/3 were still alive at 3-year follow-up, and almost 60% received life-saving appropriate therapy from the device. So even though that 1-year mortality is higher, the majority of patients are still alive at 3 years, and the majority of them were saved by having the device in place. Now, as you can see from these bar charts, the cause of death for cancer patients with ICDs is fairly equally distributed between cancer causes and cardiac causes, with the exception of all-time mortality in the primary prevention cohort, in which cardiac causes are significantly more common. So again, not necessarily that belief that cancer is always the reason that these patients are dying. It actually is relatively equally distributed. And we also have data to suggest that CRT or cardiac resynchronization therapy is beneficial in chemotherapy-induced cardiomyopathy. And that was demonstrated in this prospective study called the Made-It-CHIC study, led by Dr. Jag Singh at the Massachusetts General Hospital. And in this prospective study, 30 patients were enrolled. They had a mean age of 64. 73% were breast cancer survivors with a mean QRS duration of 152 milliseconds. Now, all echocardiographic parameters significantly improved after implantation. And in addition, New York Heart Association class improved in 49% of the individuals across the various different subgroups that were evaluated. So in summary, arrhythmias are a common occurrence with various cancer therapies, including BTK inhibitors and immunotherapy. Dedicated studies of rhythm control in cancer patients are lacking, but are necessary. Cancer patients are often not receiving guideline-directed anticoagulation for thromboembolism prophylaxis. There is an urgent need to develop cancer-specific algorithms for AFib-associated stroke prophylaxis. And finally, device-based therapies can be beneficial to appropriate populations of cancer patients, so we should not be withholding it, especially if patients have reasonable long-term mortality. I want to thank you all so much for your attention and again, the kind invitation to present today.
Thank you so much, Dr. Fradley. It was an excellent presentation, and it almost covered all the spectrum of the troubles that we found in this field. So first, I would like to open the discussion. I don't know if someone has a question for Dr. Michael Fradley.
Yes, I'd like to ask a question, Dr. Fradley. I think you made a fantastic presentation. Really, it was just so comprehensive on so many different topics. I'm really very much impressed. So my question pertains to anticoagulation in cancer patients in the setting of AF. So you've shown us a study encompassing apixaban and rivaroxaban and the bigger trend, which I imagine, based on what I've seen, is likely the result of the fact that there's more experience in those three historically than yet when compared to edoxaban. However, of course, when we look at the VTE trials, then edoxaban is well represented there. Do you think that all four of them are an option for cancer patients in AF? Would you restrict them in any way? And also, you've mentioned that you're a bit unsure about the CHA2DS2-VASc score, obviously, whether it applies or not. Some have said that the CHA2DS2 score may be a better option for cancer patients. What do you think about it?
Yeah, well, thank you again for the invitation to present. It really is it's an honor to be here. I just wish it could be in person. But those are both really important questions. And I think they kind of really get to the heart of the complexities of trying to determine appropriate management in these patients. So what I would say is that, as best as we can tell, I think that probably the efficacy of the different anticoagulants or the DOACs are probably equivalent in terms of their benefits for thromboembolism reduction. The big question, I think, is going to be related to bleeding risk and the drug-drug interactions that may go along with it. So there at least, seems to be a general strategy to utilize apixaban more frequently because the bleeding rates, at least in the general population, seem to be somewhat lower. The factor Xa inhibitors do impact CYP3A4, which is obviously a significant pathway that is also impacted by many different cancer drugs. But even in that setting, it doesn't seem to lead to substantially increased bleeding rates, at least also in the DVT literature. So I think that those drugs, probably the factor 10A inhibitors, are going to be utilized more widely than, say, something like dabigatran, which impacts P-glycoprotein and may have some more bleeding complications because of that specific pathway impact. As far as the CHA2DS2-VASc score, again, another really important question. There's some data out of Taiwan that looked specifically at the CHAD score, as you pointed out, and that the CHAD score may be a more useful guide for management decision-making in cancer patients. I think ultimately we probably need to figure out a way to actually incorporate some of the unique components of the cancer itself into the decision-making. And so I think that probably neither the CHA2DS2-VASc score nor the CHADS score is really sufficient or adequate for these patients. And we're probably going to need to really look at some of these unique aspects of cancer. And it's probably also not going to be cancer broadly, but it's going to be cancer subtype specific. So how you might approach a breast cancer patient may be different than how we're going to approach, say, a myeloma patient, because I think that, again, the thromboembolic risk is probably not equivalent across all cancers.
Thank you very much.
Okay, I have a question to you. So do you think that you talk about AF ablation? And so do you think that AF ablation should be considered more routinely in cancer patients, despite what you said about the higher bleeding risk? And I'm asking this because this is because in the general population, it seems particularly useful in sicker patients, such as patients with heart failure, like the Castle trial shown. What is your take on that?
Yeah, I mean, I think that we probably should be using it more frequently. You know, the complexities obviously are one, the patient needs to be able to be maintained on anticoagulation for at least 3 months post treatment. So that's one area that, you know, will eliminate a certain proportion of patients from consideration. But assuming that they can be maintained in anticoagulation, then I think it's probably worthwhile to at least be doing it. But I think it would also be worthwhile to probably incorporate these patients into some sort of a registry where we actually are following them and seeing if outcomes are truly equivalent. Because that's, I think, the big question is we don't have a lot of efficacy data. As far as the data regarding bleeding, it does seem that there is more bleeding, but major life-threatening bleeding is not significantly increased. So, you know, I think from a safety standpoint, I think with the current way we approach it, I think it's still a very reasonable option. But efficacy is the big question.
Okay, I totally agree with you. And we have a question from the audience. What is your approach for the antithrombotic therapy after LAA occlusion in cancer patients?
So right now we just use the same recommendations that we would for any patient that is receiving a left atrial appendage closure device. So you know, we do the anticoagulation for, you know, at least 6 weeks to 3 months, depending on the circumstance. But you know, there is an ongoing trial, if I understand correctly, that is looking at whether or not you need that short-term anticoagulation in patients, or if you can, you know, just immediately go to either DAPT or even just aspirin. And I think that those data are going to be so important, because if it appears to be reasonable to go to, say, just aspirin therapy, then I think left atrial appendage closure devices are going to become a really important component of cardio-oncology care. Because we know so many of these patients are going to have problems. If we can minimize their stroke risk early on with a appendage closure device, we're going to probably start utilizing them more. But it's really going to be dependent on whether or not we can safely get away with aspirin monotherapy. And then it's going to require, I think, also looking at cancer patients specifically to ensure that the potential prothrombotic risk that exists in the setting of cancer doesn't impact, say, endothelialization or thrombosis potential on the occluder as well.
Thank you. There are more questions for Dr. Fedley?
Yeah, I can ask you, I guess, another question as well. So still, with regards to, I guess this both applies to LAA occlusion, but also to anticoagulation as a whole, because we were discussing risk stratification, which patients to treat. Do you think that cancer itself, or maybe some types of cancer, like they do it in the Corona score for VTE, for example, do you think that some kinds of cancers should count as a risk factor, even if a patient has a CHA2DS2-VASc of 0 or a CHA2DS2 of 0 per se?
Yeah, that's a great question. And I think that my opinion is yes, but is that based in any fact? No. And this is, I think this is, kind of also getting at the heart of kind of cardio-oncology and now sort of, bringing in electrophysiology into this mixture. We don't capture a lot of these data in any of the different registries that exist, whether they're on the oncology side or on the cardiology side. And I think that there probably is different risk based on different cancer. But we just need to start capturing the data and looking and seeing. Because that, I think, is going to be essential in creating some of those cancer-specific algorithms. Because I really don't think that if we just say, added cancer to the CHA2DS2-VASc score, I don't think that's going to have a huge impact. But there are going to be certain ones that are going to really impact the likelihood of thromboembolism.
Thank you. I agree.
There are more questions. Yeah. I think there are no more questions for you. So thank you so much for being here with us to have this wonderful discussion about this important theme. Thank you so much.
Thank you so much for the invitation. Everyone have a nice afternoon.
So, good afternoon, everybody. My name is Daniel Caldera, and I have the pleasure to announce the next speaker, which is Dr. Miguel Nobre Menezes. He's a cardiologist. He's a cardiologist dedicated to interventional cardiology and also to cardio-oncology. So he's the perfect person to speak about thrombosis and antithrombotic drugs in this context. So, Miguel, the stage is yours, please.
Hello, everyone. This talk is about anticoagulation in patients with cancer, a very important topic today with recent developments. Now, for the sake of time, and also because the amount of evidence is much greater, we're only going to cover venous thrombosis in this talk. Now, VTA and cancer are often go hand in hand. Some would say, indeed, that cancer is the risk factor for VTE. Having said that, not all cancer is alike, as the rates of pancreatic cancer, for example, in terms of VTE are much more of a problem than what happens with, for example, breast cancer. Nonetheless, as a whole, cancer is indeed a very, very important risk factor for VTE. Not only that, but cancer patients always tend to have greater recurrence of thrombotic events as well as bleeding events. And if that wasn't enough, there's a clear synergy for mortality when we consider cancer and VTE, because the risk of mortality from both happening at the same time is much greater than the risk of mortality for each of them isolated. Now, why is it that these two go hand in hand so clearly? And the reason for that is because there are many, many shared risk factors among cancer patients that clearly, very clearly favor VTE. There are specific aspects to the cancer disease, such as the primary tumor locations that I had already mentioned. And also, generally speaking, the more developed the cancer is, the worse. So recent diagnosis, metastatic disease, advanced cancer is much worse. There's also the fact that there are non-cancer factors that are very common in cancer patients nonetheless, which are classical risk factors. And then there's the therapies. There are specific chemotherapy drugs, there's the radiotherapy, there's surgery, there's central lines, there's transfusion products, and all of these, of course, increase greatly the risk of VTE in cancer patients. And so this graphic nicely sums up why this is such a big problem. Now, despite all of this, estimating VTE risk in cancer patients is quite difficult, actually, and there haven't been many scores that were successful at it. Perhaps the best known of them all is the Corona score, which is very simple to use and nicely lays out the risk of having a VTE if you have cancer. This score has, of course, been criticized for being overly simplistic, but generally speaking, when something is simple, it's used, and that's quite important in this particular setting, and has become increasingly important in recent years, and we'll see why in a few minutes. Now, when we think about anticoagulation patients with cancer and VTE, we think about two main settings: secondary prevention and primary prevention. And I'm going to focus on what is perhaps the most important one of them all, which is secondary prevention, which is also where we've got the vast majority of evidence. Now, for the past 15 to 20 years, there was really only one option for cancer patients when anticoagulation was needed for VTE, and that was low molecular weight heparin. That dates back to the CLOT trial back in 2003, where it was clearly established there was a better option when compared to the warfarin, which is what we had back in the day. Now, when we think about DOACs, however, DOACs are currently a much better option for secondary prevention than heparins because they're a lot more easy to use in the general population. And indeed, in the general population, they have been compared against warfarin, which was the alternative that we previously had, and the results were very good. They were at the very least as effective as warfarin and clearly had a better safety profile. But do these apply to the cancer population? And the fact is that based on those trials, we simply did not know until just a few years back, because there were very few cancer patients in those trials. And not only that, but also most of those patients weren't that sick. Few had metastatic disease and few were under active treatment. And so while the results of these trials in the subgroups of cancer patients were generally encouraging, we simply didn't know until a few years back. Now, 3 years ago, the Akusai VTE cancer, named after the famous Japanese painter, was published. This was a landmark trial, and a very, very important one, because it was the very first time that a DOAC drug was proved to be effective in cancer patients. Now, in this trial, edoxaban was compared to the gold standard at the time, which was dalteparin. And this was truly a challenging population because, as you can see here, almost every single patient had active cancer. More than half of them had metastatic disease, and recurring cancer was also a very, very prevalent factor in this population. And I dare say that the results did not disappoint because edoxaban showed a trend towards greater efficacy than dalteparin, albeit at an increased risk of bleeding. And when we think about where bleeding came from, well, it came from what it usually comes in DOAC trials, which is to say it came from the GI tract. But it was generally manageable. It was very rarely fatal. And as you can see here, not all the GI tract is made equal, as most bleeding came from the upper gastrointestinal tract rather than the lower gastrointestinal tract, even though most patients with cancer in the GI tract had it in the colorectal location rather than in the upper GI. Importantly, there's detail here that might have actually exaggerated these results in terms of bleeding, which was the fact that the edoxaban arm had 50% more cases of upper GI tract neoplasms when compared to the dalteparin. So actually the balance of this distribution might have favored dalteparin rather than edoxaban, and therefore exaggerated the bleeding results, favoring again dalteparin. Now, shortly after this trial, the SELECT-D trial with rivaroxaban was published. This was an extremely similar trial to the edoxaban trial. However, it was a phase 2 trial with much fewer patients, less than half the patients to be exact, but the results were largely similar. Rivaroxaban showed a trend towards greater efficacy at an increased risk of bleeding. And again, most bleeding events originated in the gastrointestinal tract. Now, importantly, there's a third player here which has come into place, which was apixaban. Apixaban had already shown promise in the ADAM trial, which was a very small trial published last year. But a few months later came the results of the highly anticipated Caravaggio trial, named after the famous Italian painter. Now, this trial was very similar to the Okusai VTE cancer trial in the sense that you had a very challenging population and also a very large one at that, about a little over 1,000 patients, just like in the Okusai VTE trial. The vast majority of patients had active disease, and many of them had either recurrent or metastatic disease, although we don't know how many of them actually had metastatic disease in detail, which are the most challenging patients of all. But this trial surprised the scientific community in the sense that apixaban showed also a trend towards greater efficacy, but without an increased risk of major bleeding, which is quite a surprise because it differed from both rivaroxaban and in particular from edoxaban. Now, I think that we need to think about why this was the case, and in my point of view, and this is a personal interpretation, there are two major reasons why this might have happened, and they're not mutually exclusive. The immediate reaction would be to say that apixaban just has a better hemorrhagic profile than the others. We had already seen in the AF trials that it was the only DOAC that didn't have an increased rate of GI bleeding. However, when you look at the details of the trial, there's another possible explanation that might explain why this was the case. And indeed, you remember from Hokusai VTE trial that while there's a lot more colorectal cancer than upper GI tract cancer, most GI bleeds come from the upper GI tract. And what happened in the Caravaggio trial is that in an exact opposite what happened in Hokusai trial was that the dalteparin arm had a greater amount of upper GI neoplasms than did the apixaban. Now, this, of course, favors the apixaban arm, and this is exactly the opposite of what happened in the Okusai VTE trial. So it might also be that there was simply a bit of luck in terms of the distribution of neoplasms in this trial, and this is why apixaban has such a good performance. I guess that, of course, we will never know exactly which was the cause. And again, these explanations are not mutually exclusive. And so it may very well be that apixaban may have a bit of a better profile in terms of bleeding. And when making choices, of course, we have to rely primarily on results of the trials. But this is a relevant detail nonetheless from my perspective. Now, there has, of course, been a meta-analysis considering all of these three trials, which largely shows what we've just seen. So in terms of thrombosis efficacy, DOACs were clearly at least as effective as dalteparin. They seem to be perhaps even more effective than dalteparin, albeit at risk of increased bleeding. In terms of mortality, there has been no complete difference overall, although there's a trend here favoring DOACs as well. Now, guidelines have been slow to react from my perspective to these trials, but they have reacted nonetheless. And since last year, both general guidelines as well as oncology guidelines have started embracing the use of DOACs for these patients. They started, of course, with edoxaban and rivaroxaban because the results of the Caravaggio trial was not available at the time, but still they've increasingly recognized their usefulness. And there's even these algorithms that show how one might decide in these particular situations. And of course, if the bleeding risk is overall low, then certainly DOACs should be the preferred strategy. If, however, there's a very high bleeding risk, especially if we're dealing with an upper GI cancer, then perhaps low molecular weight heparins were the best option. The cardiology guidelines, which were released recently in past year, have also adapted to these new reality and have already included bortezomib and rivaroxaban because of the OCCIDE trial and because of the SELECT-E trial as the best alternative for patients with cancer, provided the GI cancer is not involved. Now, another important question is, how long should we anticoagulate patients? And there's no real answer in terms of cancer patients here, but perhaps the answer may come from the DOAC trials in the general population, where there was a very, very large reduction in the rates of recurrent VTE, so long as DOACs were maintained. And guidelines do follow this principles by saying that we should go for at least 6 months, which was the duration of the trials. But other than that, as long as there's active disease, then it's probably best to maintain anticoagulation indefinitely, unless there, of course, a very important contraindication arises. And so in this table, you can see where we stand in terms of best evidence in 2021. And it's quite remarkable that in just 3 years, this table has grown from 2 options to 5 options, and that 3 of those are oral rather than subcutaneous. Now, moving on to primary prevention, this is an area where we know a lot less than in secondary preventions. There have been some attempts of finding strategies for primary prevention in cancer patients, again, starting with low molecular weight heparins, but they've had very modest success because it's very difficult to keep patients on these drugs in a primary prevention setting, especially due to adherence problems. And so this really never ended up not catching up at all in terms of a general approach. But things have changed since the new trials have been published. And the first drug to come up with an option was apixaban, this time with a very important trial, which was published a couple of years ago, which included 563 patients with an at least intermediate VTE risk. And this used the Corona score for stratifying patients, and this is why this score is now quite important. And what did they find? Well, based on a difficult population with a lot of challenging cancers, namely pancreatic cancers, a dosage of apixaban, which is half that of secondary prevention, 2.5 milligrams twice daily, very significantly reduced the rates of VTE. Of course, there was an increase in bleeding, as you'd expect, but if you look at the graphs, you will find that the reduction of VTE is much greater than the occurrence of bleeding, which means that the overall net benefit actually favors the institution of DOAC therapy in this setting. Now, again, bleedings were mostly manageable in general cases, and so this wasn't as much as an issue as one might think, as most bleedings were not major. Importantly, there were no fatal bleeding events as well, which further highlights the good safety profile of apixaban in this particular setting. The second drug to test this approach, and it was very similar to that of apixaban, was rivaroxaban with the Cassini trial, which was also published just a couple of years ago. Here, the intention to treat trial failed to meet its primary efficacy endpoint, but when we look at events during the intervention period, that's to say the on-treatment analysis, rivaroxaban have a very similar efficacy than that of apixaban. Of course, there was an increased risk of bleeding in the rivaroxaban arm, but again, most bleeds were not major and were mostly manageable. And so these 2 trials were very important because for the first time, there was a simple way of stratifying thrombotic risks in the setting of primary prevention. And when we think of best evidence options, I would argue that these are currently the 4 that are available. And I would also have to say that those with DOACs have much higher quality and scientific robustness than those of VT because they're much larger and cover a much longer follow-up period overall. Now, guidelines have indeed also caught up with this evidence, and even oncology guidelines have started to recognize that both apixaban and rivaroxaban are an option for selected patients at high risk of VT and cancer. Lastly, we often don't like to talk about money and costs in Portugal, but importantly, costs are an issue and they must be taken into account. And here I have the updated prices in Portugal for both apixaban, rivaroxaban, and edoxaban, and two of the most important low molecular weight heparins available. And what you can see here on this table is that both for the patient and us all, the costs of low molecular weight heparins are 3 to 5 times greater than those of DOAC trials. So as far as cost is concerned, this is, of course, a no-brainer. There are, however, of course, other challenges in cancer patients we should also take into consideration. DOACs may not be an option always, of course, because oral availability is not always an option. We do need to bear in mind the risks of thrombocytopenia and coagulopathy, which might limit us in terms of the use of these drugs. Renal and hepatic failure may also be an issue for the use of anticoagulation in these patients. And of course, there are a few drug interactions that may be taken into consideration when selecting a DOAC, although I must say that the experience that we've had in cardiology for the past decade has shown that these interactions are seldom clinically relevant. And so I don't think that they're much of a problem for the vast majority of cases. So I would finish with the take-home messages by saying that the risk of thrombotic events and its recurrence is very, very high in cancer patients. That while bleeding is also an issue, thrombotic events are generally in absolute numbers particularly relevant and should therefore be taken into consideration in every single patient primarily, and probably over bleeding issues. Primary prevention is still an open issue, but the two trials that I've mentioned completely changed the panorama. And this, of course, is mostly a decision of the oncologist rather than the cardiologist. For secondary prevention, treatment duration should last at the very least 6 months. But now that we have DOACs, we should probably consider anticoagulating patients indefinitely, so long as cancer remains active and there is no absolute contraindication. There's a large amount of evidence supporting the use of DOACs in cancer patients. Direct evidence currently comes from edoxaban, rivaroxaban, and apixaban. And of course, when you think about convenience and you think about cost, DOACs are, of course, a much better option. And when we think about specific options, we've got for secondary prevention currently edoxaban, rivaroxaban, and apixaban, and for primary prevention, apixaban and rivaroxaban. Thank you.
So thank you very much, Dr. Miguel Nobre Menezes, for your insightful presentation. So I think we have time for only 1 or 2 questions from the audience. Here's one question from the audience. A woman, 54 years old, lung adenocarcinoma, under treatment with alectinib. More than 6 months ago, she had a pulmonary embolism and a DVT, a large atrial thrombus that extends to the inferior vena cava. She was on low molecular weight heparin, but now, sorry. But now she's very tired. The injections and with difficulty on paying for low molecular heparin. What are the alternatives that we can consider for this patient?
Okay, thank you, Danielle. So I think that we've kind of answered the question with your presentation, right? So this is a situation where obviously from a purely clinical standpoint, you could both consider low molecular weight heparins or DOACs. And considering that she's already tired of the injections and considering the costs, I think that any of the 3 DOACs that we mentioned would be an option. So we could either use edoxaban, rivaroxaban, or apixaban. Also taking into account the number of other drugs she might be doing, and also whether a one a day pill or twice a day pill might be an issue. And sometimes whenever I see obviously cancer drugs, I often have to review whether there may be interactions, because I'm a cardiologist, and even though we deal with this quite frequently, cancer drugs are coming along, new drugs every day. And so I would first check if there's any particular interaction that I would be initially unaware of, and then select it based on those. With regards to intrachamber thrombosis, whether it be in the right cavities or in the left cavities, obviously the evidence is quite slim, but I have personally had good experience with DOACs, whether it be in right ventricular cavities, whether it be in the left atrial appendage, or in the left ventricle, for example, following a myocardial infarction. I've had good experience with DOACs, even in cancer patients. So I would say that either 3 of those DOACs would be an option.
Okay, thank you very much. Is there any other questions from the audience? If not, I'm going to slip a last question for you, Miguel. The guideline says that the DOACs should be offered as an alternative to heparins. Do you think so, or do you think the other way around? Should the low molecular heparins should be offered as an alternative? What is your opinion about that? And beyond the availability of the oral route, is there any good reason to offer heparin nowadays to these patients?
Well, generally speaking, I would say it's the other way around. Absolutely. I mean, I just think that there was a clear separation between the cardiologist's view and the oncologist's view initially, because obviously the oncologists were used to heparins for 15 years. And I remember standing in meetings and being the only cardiologist, and I sort of felt like an alien proposing DOACs to cancer patients when they were so used to low molecular weight heparins. So I think that the guidelines reflect that history. I would think it definitely should be the other way around. I think that apart from oral route, we certainly could consider heparins in case of upper GI neoplasms, especially if the endoscopy characteristics would tell us that managing a bleeding complication would be particularly difficult, because it's also quite different among patients. So talking to the GI specialist can also be useful in making that decision, but it's pretty much the only situation in my personal view.
Okay, thank you very much. Some last words for a last minute question, if it's possible, about vena cava filter. Is there any role for vena cava filters in DOAC era?
Well, I would say that I can't really say that there's absolutely no role, but I would say that it's certainly very, very, very slim as a general rule of thumb.
I would add that in the cardiology language, vena cava filter would be a bailout solution.
Yeah,
in
exactly.
my opinion. Okay.
Exactly. Okay. Absolutely.
So thank you very much thank you very much to Dr. Miguel Nobre Muniz and the audience for their questions. And I will close this session. Thank you very much.
Thank you.
Okay, it's me. Hi, everybody. Let me just put this. My name is António Vaz Carneiro. I'm an internist and a full professor at the University of Lisbon School of Medicine. And I was asked to present Dr. Menezes. And so you can't leave. You just have to stay there. All right, so don't leave. Because we're going to talk about something that we are interested have been interested for quite some time, which is in artificial intelligence. As everything in life, especially in medicine, there's a lot of fashions and trends. And if you pay any bit of attention, then things like digital health, precision medicine, outcome-oriented practice and artificial intelligence have become the buzz for a lot of research and interest. The concept is really very interesting. The results, we still have to wait and see. Most of the publications on in artificial intelligence in health, and there's a lot of artificial intelligence in health, of course. Lots of equipments that we work with have already incorporated artificial intelligence, but that's not the artificial intelligence that I'm talking about here. It's basically, first of all, pattern recognition in terms of imaging. There's a lot, but more interesting than that would be the emulating of the clinical reasoning. In other words, can we do some kind of modeling that can help doctors to think better and support them? So this is really an interesting field, and so I'm looking forward to hear Dr. Menezes talk about artificial intelligence in cardiology. Should the doctor take the leap? Of course, the answer, you will have probably different opinions about this. I know what I'm going to say. So without further ado, I will ask Dr. Menezes. First of all, I'll say hello to Dr. Menezes, and then I will ask him to go ahead and you have the floor. At the end, I think we'll have 3-4 minutes for questions. So we'll then talk later. Dr. Menezes, please.
Hello, everyone. This talk is about artificial intelligence and whether or not doctors should take the leap on this very new frontier subject. So I'm going to be covering mostly 3 major topics in the realm of artificial intelligence. First of all, I'm going to talk about fundamental concepts, how it works, how to get it in motion, why it's happening right now. And this particular part is aimed at people who have very small concepts about artificial intelligence, but also about those who know a little bit more about it. Next, I'm going to give you specific examples for current and future applications in medicine, and in particular in cardiology and oncology. And lastly, I'm going to talk about something that is also very important, which are the limitations of artificial intelligence in medicine, because for all the hype it carries, I think you do need to grasp that it's not a completely unlimited topic. So, starting with fundamental concepts. The concept of artificial intelligence is not new at all. We're talking about something that was introduced in the early 20th century in 1936 by a very famous scientist, Alan Turing, who is best known for cracking the Enigma code, the German Enigma code in the Second World War. But in this paper, he basically laid out the foundations of the concept of artificial intelligence. Now, of course, this was all very theoretical because there weren't even computers to begin with, and thus the concept stayed very much in sleep until more recently, where there's a lot of hype and there are a lot of review articles. Now, the concept of artificial intelligence as an intelligence broad enough to truly rival that of humans is currently not existent. What we do have is specific programs that can write themselves to do specific tasks. So what we have on a normal program is you put the input, somebody writes the program, and then the computer produces an output. In the realm of artificial intelligence, on the other hand, what we do have is a program that writes itself. So what you feed is both the input and the output, and then the model trains itself, such that when it's ready, it can deliver the output based on the input, but nobody has actually written it. Now, to do this, you need to use something called a neural network. A neural network is not truly composed of neurons, but is instead composed of snippets of code, which are nodes, but because of the fact that they resemble neurons, they're called neural networks. And the thing about these nodes is that they can communicate amongst each other. They can communicate both forward and backwards, doing what's called as back propagation. And again, this is not a new concept either, because it dates back to 1986. Now, today, what we do use is these neural networks just the way they were laid out in the 80s, but they're much more complex because there's a lot more computing power. And these neural networks have many layers, and because they have many layers, they are called deep neural networks, sometimes referred to as well as convoluted neural networks, which is a type of deep neural network, but the terms are often used interchangeably. And so when we look at a broad view of AI, we can think of AI as an intelligence that would match humans, which currently does not exist. You can think of machine learning as the methods that machines use to learn how to perform very specific tasks. And the process by which they're learned is called deep learning. Now, there are many types of machine learning methods, and for the purposes of medicine, I've chosen to highlight these three. There's supervised learning, where you feed something into the algorithm and you teach it what it is. This is, for example, used for the purposes of learning how to interpret images, for example. There's unsupervised learning, where you feed a lot of data into the algorithm and you don't know what you're actually looking for. You just let the network learn by itself. And this is used in pattern recognition, in risk stratification, and trying to find relationships between data that you don't know it's there. And so it's kind of like uncovering patterns by not using conventional statistical methods. And then there's reinforcement learning, where the network has been trained already, and you just feed it more and more and more data to make it more and more and more accurate. And this can also be used for the purposes of imaging, or can also be used in gaming, for example, as well. Now, as I've said, AI is not a new concept. It's almost 100 years old. And so the question is, why is it that there's so much hype about AI these days? And the reason for that is because we're currently living in a perfect storm moment, where all of these four elements are now aligned and can at least partially deliver on the promise of AI. Now, first of all, there's what we call open source. So AI is no more than actual computer code. It's not like you can use an app and do AI training. That currently does not exist. What you can see here on this little snippet of code is code for a relatively simple layer, for example, a very crude layer. But the fact is, there's a lot of open source data detailing how to do this. Not only that, but there are open source frameworks which already have pre-trained neural networks that you can tinker with, but that you don't have to write from scratch. And the two best known ones are TensorFlow and PyTorch. TensorFlow is backed by Google. PyTorch is more of an academic framework, which is mostly backed by Stanford, but they're the two probably better known frameworks for using AI. And they just make the process not simple, but certainly simpler and much, much faster. And what they do have, for example, in this particular network that's recognizing animals, is they've already got pre-trained complex deep learning networks in which each layer has a specific task. And so you just have to tinker with it to get the achieved result. And we're going to see examples of that in just a moment. Then the other thing that you have is that you have to have access to cloud-based data and also a lot of computing power to pull this off. So the problem with training models is that it takes a lot of time. So if I were to use my computer that I'm using right now, which is just a regular laptop, to make a training process of, say, 10 images, that would in all likelihood take me no less than 24 hours to achieve a full reasonable training. And this is just for 10 images. Imagine when you have thousands of images you have to train. So you need a lot of computing power, and you access it via the cloud, via the web, by using, for example, Google's computers that you can rent. And so it's the internet that has also enabled that. And lastly, there is, of course, big data. Big data is only possible thanks to the internet revolution as well. That makes it possible to share enormous amounts of data amongst ourselves. Now, examples of classic teachings in artificial intelligence. One of the most useful teaching examples, which is often used for taking the first steps in neural network trainings, is the MNIST data set, which is basically a pre-trained network that you can use to show how to recognize handwritten numbers. This is a classic example. But then there are more spectacular examples. One of the better known ones is the game of Go. So the game of Go is kind of like the Asian chess. And a few years ago, an AI algorithm actually started beating human players very easily, even performing with moves that had never been tried before by humans. And even more interestingly, when you've used reinforcement learning processes, the algorithm actually managed to beat itself. So this is one of the examples where very complex tasks with very specific ones can truly be undertaken by AI algorithms. Another very famous example, which is exceedingly important, including for medicine, is the ImageNet project, which was and is a massive project of image recognition, which encompasses a lot of images, a lot of people, a lot of countries, and which is basically what has been used for recognizing everyday objects. And it's gotten very, very good at it. It's so good at it, in fact, that in certain settings, it can even surpass that of human knowledge. But again, like I said, it's very good at performing specific tasks. So you can see on the left that it's able to recognize airplanes and it's able to recognize some degree of context, but you can see on the right that it's not as good in recognizing more complex contexts, especially those that deal with emotions, and sometimes still makes some pretty crude mistakes like the one you can see on the right here. Another example of AI in motion is objects that we use every day, like Google Assistant, Amazon Alexa, Tesla's Autopilot. They're all examples of fantastic AI algorithms that we work with and use every day. Again, they're very good at specific tasks, but they can't do very broad reasoning. So if you talk to Alexa or Google Assistant, they will be very effective at answering back at you, but they have to know which language we're speaking with, right? So if I start talking to them in Portuguese instead of English, they will not be able to understand me. And it's just a good example how there's still no such thing as a broad AI that can actually mimic that of a human. And so when we think of applications to medicine, machine learning can be used for predictive analysis, for risk stratification, for virtual assistants. It can be used by partially automating clinical decision support. It can be used and is used a lot for image recognition and may even in the future be able to control some degree robotic systems for surgery, for example. Now, moving on to the second phase of this talk, which is I'm going to give you some examples of current and future applications in cardiology of oncology, some of which are of our own group's making already. Now, one of the most important things in AI is, of course, estimating left ventricular function, and there are some fantastic papers already on this. Here you can see one where you have a clearly normal left ventricular function, and a machine learning algorithm is actually able to tell you as accurately as a human that this is a normal left ventricular systolic function. More impressively, even perhaps, has been the paper published by David Young's group last year in Nature, where if you throw an LV echocardiogram image at it, it can actually completely identify where the LV is, and it can also interpret whether what the ejection fraction is exactly. Now, it's important not to confuse this with what we currently have in our echocardiogram machines, because in our echocardiogram machines, we have to tell them where the basal septum is, where the apex is, and so forth. And in here, it's doing it all completely alone. So it's really quite revolutionary. Not only that, but in echocardiography, there is also papers that show how it can very specifically determine and identify pathological patterns, which might also be useful in specific settings as well. MRI is another field where AI has also been scoring a lot of points lately. You can see here that for interpreting an MRI of a heart, a neural network, a well-trained neural network, is not only extremely reproducible, but much, much faster than a trainee and even an expert in interpreting and calculating, automatically calculating stuff on an MRI. Now, even more impressive is perhaps the fact that you can, with AI, uncover patterns in very old exams. In this particular paper, for example, you can see here that a neural network is capable of suspecting the presence of an aortic stenosis based on an ECG. But when you try to look at the details, you can see that it's not just looking at a pattern that resembles that of hypertension, for example, it's looking at a very specific setting of the ECG, such as the one on the STT segment of the ECG, but a very specific one that we usually wouldn't tend to look at so clearly. And so it's another example of uncovering hidden patterns that the human eye just isn't able to. Again, in aortic stenosis as well, you can see here another example of automatic measurements for TAVI, which are highly reproducible, highly concordant with experienced operators, and much, much faster. Another important issue where AI can be very useful is in coronary artery disease, where you've got image segmentation and interpretation. And this is one field where our group has been working on. I've been working at this for a little over 2 years now, and the process is quite cumbersome, but it's already bearing some fruit. So what we're trying to do is to interpret coronary angiograms. This is a very cumbersome test. Like I said, it involves a translational approach with doctors and engineers. And what we do is we look at a coronary angiogram. We do the segmentation manually, which you can see on the right, and it is a very cumbersome process. Like I said, very slow. Like I said, and we're training an AI network to do this. We're still very much in the beginning, but you can see here one of the examples produced by the network. And of course, it's not as good as the humans, but considering that this is still very preliminary, it's quite impressive indeed. Another thing that we've also been doing.
Alô? Alô?
Oi, boa tarde, doutor Renan.
Miguel, I think we can go on speaking.
It's recorded, Professor,
Yeah,
so it was just a technical issue.
I'm sorry, I asked the manager of this meeting to mute everybody, please, except Miguel. Can you do that? Because you have all this noise.
I'm doing that, Professor. Just let me launch the video again.
Thank you, thank you.
Out there still not, and specific settings as well. MRI is another field where AI has also been scoring a lot of points lately. You can see here that for interpreting an MRI of a heart, a neural network, a well-trained neural network, is not only extremely reproducible, but much, much faster than a trainee and even an expert in interpreting and automatically calculating stuff on an MRI. Now, even more impressive is perhaps the fact that you can, with AI, uncover patterns in very old exams. In this particular paper, for example, you can see here that a neural network is capable of suspecting the presence of an aortic stenosis based on an ECG. But when you try to look at the details, you can see that it's not just looking at a pattern that resembles that of hypertension, for example. It's looking at a very specific setting of the ECG, such as the one on the STT segment of the ECG, but a very specific one that we usually wouldn't tend to look at so clearly. And so it's another example of uncovering hidden patterns that the human eye just isn't able to. Again, in aortic stenosis as well, you can see here another example of automatic measurements for TAVI, which are highly reproducible, highly concordant with experienced operators, and much, much faster. Another important issue where AI can be very useful is in coronary artery disease, where you've got image segmentation and interpretation. And this is one field where our group has been working on. I've been working at this for a little over 2 years now, and the process is quite cumbersome, but it's already bearing some fruit. So what we're trying to do is to interpret coronary angiograms. This is a very cumbersome test. Like I said, it involves a translational approach with doctors and engineers. And what we do is we look at a coronary angiogram. We do the segmentation manually, which you can see on the right, and it is a very cumbersome process. Like I said, very slow. Like I said, And we're training an AI network to do this, and we're still very much in the beginning, but you can see here one of the examples produced by the network. And of course, it's not as good as the humans, but considering that this is still very preliminary, it's quite impressive indeed. Another thing that we've also been doing is not just segmentation of coronary angiograms, but also automatic lesion identification, where we've used pre-trained neural networks for recognizing other objects, some of which quite familiar to human eye, and then retraining that neural network to automatically detect lesions. And we've already gotten some pretty interesting results that we hope to publish quite soon. And lastly, because all of these examples largely pertain to imaging, I'm just going to show you a couple more, which has got nothing to do with imaging. Here's an example where we throw in an impressive amount of data in a neural network, and it is able to do a phenotyping event prediction modeling that is actually quite robust and accurate, and one that we couldn't, with classical statistic methods, uncover. And another example, for decision making, where you can see here the high degree of concordance between a trained AI algorithm and an expert in oncology for deciding on, for example, chemotherapy and other treatments for oncology disease. Of course, all of this has been leading to a lot of buildup in the industry. There are a lot of companies brewing that are currently developing. And so I absolutely think that we doctors need to jump into this field and be a part of it, because it is moving indeed very, very rapidly. And we're honestly not going to get to decide whether it's going to move forward or not. It just will move forward. And the decision we need to make is whether we're in or out. Now, lastly, and very important, limitations of artificial intelligence. I'm not going to cover them all, of course. I'm just going to cover those that I find are particularly relevant for the sake of medicine based on my own experience. And perhaps the biggest challenge of all is data availability. Now, you've seen the ImageNet database with millions of images. Getting millions of images in medicine is very complicated. Not only are, of course, the data sets in medicine are much smaller, because the number of patients, thankfully, is much slower than the number of normal people, but also data in medicine is generally quite closed. Doctors don't tend to share it amongst themselves, and then there are, of course, a lot of privacy and legal issues associated with medical data. And so data availability is a big, big problem with regards to the development of AI in medicine. The second problem with AI are operational constraints. I've shown you that, for example, for the purposes of segmentation of a coronary angiogram, you have to manually feed it a lot of images. Now imagine multiplying that by thousands of images. It just takes a lot of time and a lot of work. And so it's very difficult to build robust data sets based on medical work, which is already scarce. And so this is, again, a very, very, very big problem in my perspective. And perhaps the biggest problem of all is, how do we interpret what comes out of an algorithm? So the problem with this is that I'm showing you this example here again, and this algorithm is building a very interesting risk stratification model, but we don't really know how it gets there. And that's one of the biggest problems. So it seems right, but what if it's interpreting it incorrectly? And when we try to generalize it, it doesn't work. And I'm just going to show you an example of what I mean that is actually a lot more clearly based on my own experience. One of the things we've tried as part of our works was actually trying to teach a model to simply distinguish whether we're talking about a right coronary artery or a left coronary artery. And the problem is that when we started training the model, we could tell that the model actually got very, very, very good at predicting whether it was an RCA or an LCA. But then when we try to understand how it was actually doing this, we've used something called the GradCam map, which basically highlights in color where it's looking at in the picture. And here you can see an RCA, but if you look at the GradCam map, you can see that it's not looking at the artery itself. It's just looking at other anatomical landmarks. There are typical of RCA projections, and thus it is correctly identifying which artery it is without actually looking at the artery. So we're not really sure whether this would work if we significantly change the image. Probably not. And it's just an example that highlights the dangers of misinterpreting what the AI model is telling us is right, because it may be basing itself on a wrong premise. Still then, trying to answer the question that I've laid out in the beginning of this talk, Can and should doctors take the leap? I absolutely think that yes to both. Doctors must take the leap into AI. It's here to stay. It involves a lot of collaboration with engineers, but it's also quite fascinating, an area to dive into because it just offers so many possibilities and so much learning opportunities that I absolutely do think that we can and should take the leap. Thank you.
Very well. Thank you. All right. Hold on just a second. I get the feeling that there's no foreign people here on the audience, but I'll speak in English. I'll speak in Portuguese anyway. Okay. Thank you, Dr. Nunes. Now, is there a question? We have like 3 or 4 minutes for a question or two. This is very interesting stuff. Why do you think the question? Let me ask you this. Now, one of the biggest basis for artificial intelligence to work in medicine is access to big databases. As a matter of fact, the result of artificial intelligence in terms of parsing the big number of data is the size of the data. The bigger the size, the more efficient the artificial intelligence program will be. I'm talking about machine learning and neural networks. That's what I'm talking about. So it should be fairly adaptable to medicine that produces huge amount of information on every single day. There are some data that shows that the information now available for each patient in terms of pages will be like the entire work of Shakespeare. So each one of us has the entire works of Shakespeare worth of data. Now, one of the things that I think would be more interesting would be definitely to do, in a certain way, a precision medicine in which to go to look at all this data and identify subgroups of patients that our own eye and experience cannot do it. In terms of, for example, the diagnosis in terms of response to therapy. Let's say, to give you an example, let's say somebody has a colon cancer, and we have a database that has about 3 million people with colon cancer around the world, or something like that. And we identify that people obese, the obese people, they have a different type of response. They don't have as good response as the other guys do when we are treating this cancer. Is there any relationship between obesity and colon cancer? I have no idea. But don't you think this would be extraordinarily useful to support medical decision making, clinical work, having this type of pinpointing of all the patients that we have, specific areas in which we can, for example, put them on different subgroups of gravity of disease, and then identify on top of every information that we have already, this information from the artificial intelligence saying something specific about that patient, for example, concerning anticoagulation or concerning antiarrhythmic drugs. Wouldn't this be probably right now one of the most important areas?
I agree that it would be, Professor, but it's a lot more difficult than it seems. So you've mentioned that we produce a ton of information, true. But even in the setting of unsupervised learning, which is essentially what you're talking about, finding hidden patterns, there's still a problem. We have to homogenize data. So if I pick up my database of my coronary patients and someone else's, I still have to homogenize data to be able to merge those databases, and there's manual labor involved in that, and that takes time. That's one of the problems. The second big problem is, sure, the AI algorithm might uncover an incredible relationship that we never thought about, but it's the problem is we often don't know how it got there, and so that's in my view my biggest concern. So I think we'll get there. I absolutely think we do, but there still needs to be a human surveillance, so to speak, not to make mistakes, because it's harder to know that it's failing when you go for unsupervised learning. When you go for supervised learning, like image recognition, if it completely gets it wrong, you'll figure out that it got it wrong, right? But in terms of finding patterns and predicting risk, I think it's a much more challenging field.
But still, we have to accept a certain degree of messiness. I was not saying that the artificial intelligence will work directly on the data. They have to have the statistical analysis first, and then on that data, we'd add that. But you see, with artificial intelligence, I think when you look at this big data analysis, we are trying to figure out correlations that are not causal necessarily. Why on the classical studies we are looking to causality. That's why you do clinical trials and case control studies and stuff like that. Here we're just looking for correlations. Are they meaningful? Well, we don't know, maybe. But certainly, if we have a huge amount of information and a very smart program that can elicit specific characteristics of certain patients, I believe that the prognosis, the prognostication will really, really get better in terms of what's going to happen immediately. When you look at the data that you showed, the IUC curves, they are fairly good, 88, 0.88, 0.86, 0.88, but they were not that different from the others. I was expecting it to be much better. So I think there's a lot of work to be done, but I think one of the areas I would guess would be looking at this huge amount of data, trying to figure out whether I can be helped when I'm on consultation with my patient with some extra information about that specific patient that can help me figure out what would be the best way. So I think that probably should be one very interesting area. The other one is, of course, pattern recognition and all the imagiology that you mentioned all as well. So thank you very much. I think we don't have any more time. Thank you very much for your talk. And I think we can go on. Bye-bye, guys. Thank you.
Thank you.
So we are moving on our course, and now it's my great pleasure to introduce the next speaker, Professora Manuela Fiuza. Of course, she doesn't need any presentation. She's been dedicated to cardio-oncology many years now. So let's hear talking about cardiovascular disease in cancer patients.
Good afternoon, everyone. My talk is about cardiovascular disease in cancer survivors. I have no conflicts of interest to declare. So I have good and bad news. Let's start with the good ones. Statistics show that there is a sustained drop in cancer death from the late 90s until now, both in men and women. But the bad news is that in the growing population of cancer survivors, cardiovascular disease is the most frequent non-cancer cause of death. In this study, data from more than 1 million cancer patients with a follow-up time up to 14 years, cardiovascular mortality ranged from 7% in lung cancer patients to 30% in prostate cancer. The childhood cancer survival study, a large study that included more than 10,000 At the age of 45 years, about 11% of those survivors had severe heart disease, generally heart failure,
Você também ouviu mais alto hoje mesmo com o novo Power por apenas €4,99. Ligue já para 208 91 80 80.
Pai é pai. Está sempre lá, mesmo quando mal o vemos. Está sempre pronto para ouvir.
Is a 9 times more stroke than the siblings. At the age of 45 years, about 11% of those survivors had severe heart disease, generally heart failure, or requires cardiovascular treatment. Another data raises great concern is that fewer than one-third of these patients reported a visit to a medical center in the past 2 years. Although the risk of having a late event increases with age, the frequency of medical visits decreased. So there has to be a coordination between hospital teams and primary care in order to meet the healthcare needs of these long-term survivors. The long-term complications of the anti-cancer treatments are mainly related to radiotherapy, and those manifestations are generally related to coronary artery disease, to valvular heart disease, to pericardial disease and late onset heart failure. But with the late events related to chemotherapy are generally related to heart failure. Generally speaking, cancer patients face an increased cardiovascular mortality risk for lifetime. It starts with a peak in the first year of cancer diagnosis, and this represents an interplay of pre-existing cardiovascular disease, potential cardiovascular toxicities, cardiovascular risks associated with tumor burden. And this early peak is followed by a plateau of stability and then rises again. And the longer the cancer survival, the higher the chance of cardiovascular disease determine the life expectancy. So who are the high-risk patients who need a close surveillance according to the ASCO guidelines? These are patients with a high dose of an anthracyclines, like doxorubicin, superior to 250 milligrams per square meter. High dose radiotherapy, greater than 30 grays. Patients treated with a combination of a lower dose of an anthracycline and a lower dose of radiotherapy. Patients treated with a lower dose of anthracycline or trastuzumab alone, and the presence of any of the following risk factors, at least 2 cardio risk factors like smoking, hypertension, diabetes, dyslipidemia, or obesity. Patients older than 60 years at the age of cancer treatment, and the compromised cardiac function, prior myocardial infarction, or a moderate to severe valvular heart disease. Also, treatment with a lower dose of an anthracycline followed by trastuzumab in a sequential therapy. For survivorship screening, the 3 societies don't have consensus in terms of time frame of screening. Essentially, it is recommended that an echocardiogram be performed until 1 year after completion of treatment if the patients are asymptomatic, or immediately, of course, if the patients are symptomatic. But thereafter, there is no consensus, and usually it is recommended to repeat an echocardiogram 5 years later, in asymptomatic patients, of course, and every 5 years thereafter. What are the recommendations for those pregnant or to be pregnant survivors? The recommendation is to have a cardiology consultation and to have an echocardiogram prior to a pregnancy or in the first trimester of those female survivors that were treated with anthracyclines or chest radiation. And what are the recommendations regarding to physical activity? Regular physical activity is highly recommended, but if the patients plan to participate in high intensity exercise, it's important to have a cardiology consultation, to have an echocardiogram also, to define the limits and precautions for physical activity. So, caring for cancer survivors, what should be done? And is this caring done by an hematologist, by an oncologist, or a primary care physician? How does this change over time from diagnosis after the patient is dismissed from hospital? The proposal is to have a team of specialists, and this team should advise those cancer survivors screening orientation. So what to do? And oncologists should take care together with the patients, family doctors, other specialists, and have lifestyle coaches help to organize a follow-up and aftercare, and which is very important, make a plan, a survivor care plan. List potential late and long-term side effects from the treatment, including what to watch for, and then who should contact the doctor. Suggestions for things patient can do and cannot do in order to improve the health, including lowering the chances of cancer coming back, a relapse. Schedule follow-up exams and other tests. And other tests for early detection of other types of cancer, for instance, and other tests to look for long-term health effects from cancer and its treatment. So, basics for long-term surveillance programs for cancer survivors. Raise awareness of possible cardiovascular disease among cancer survivors and provide follow-up. Inform patients of the increased risk of cardiovascular disease after chemotherapy and radiotherapy. Advise and support them to make appropriate lifestyle changes. Instruct patients to promptly report early signs and symptoms of cardiovascular disease. Even in asymptomatic patients, program periodic screenings with cardiac imaging and biomarkers, particularly in those treated with high cumulative doses or with reversible left ventricular dysfunction during cancer treatment. Investigate promptly any symptom suggestive of heart failure. And finally, don't discontinue cardioprotective heart failure therapy, also with stable normal systolic left ventricular function, as long as no further cancer therapy is planned. And thank you.
Thank you so much, Professora Manuela Fiuza, for the clear presentation. So we have some minutes for the discussion. I don't know if Anybody has some questions for Professor Manuela Fiuza? If it's not, I'll ask a question, a very practical question. Okay, so what do you think should be the exams and the timeline to ask the exams for patients that that had been treated with anthracyclines?
Okay, this is a very practical question. In fact, we have that problem, is that those long-term survivors are left alone. That's the way we see it. So those patients that were treated specifically with anthracyclines, the problem usually has to be with heart failure. And that problem exists in a relatively short time. Generally, during the period, they are still monitored in hospital. Anyway, those asymptomatic patients should have, in my opinion, an echocardiogram immediately after the end of the treatment. And then if they are symptomatic and there is no dysfunction with echocardiogram, for instance, they should repeat the exam 1 year after. And then if it's okay, I believe that every 5 years it's a good time. The problem is different with the long survivors of radiotherapy, because as you know, the damage can only be present after 10 to 30 years after, and the patients already forgot, and the clinicians also, that the patient had a cancer in the past. And that's the problem. So the patient and the clinician has to be educated, has to be alerted, and at the same time they are screening for relapses, and they ask for biomarkers, the cancer biomarkers. They should include 2 simple exams. I mean, in the asymptomatic patients, of course, 2 simple exams, an electrocardiogram and an echocardiogram. And this alert can be done by the patient, or the patient can carry some card or some dismissal note, for instance, and alert the GP, for instance, or alert the hospital doctor to don't forget to ask for those 2 simple exams that can make the difference. Okay.
Okay, so I totally agree. I think education of the patient needs a very good take. The patient had survived to a cancer, a disease, but needs to know that they have an increased risk of cardiovascular disease. So I think it's very important to educate and to stimulate a healthy lifestyle. I don't know if we have questions from the audience.
I have a question as well, Professor. What do you think of the following? We're currently not doing this at all, of course, but there's a clear trend for the usage of calcium scoring regarding coronary disease in CT. I'm not talking about angio-CT, but just calcium scoring, because it can be done with the current technology exceedingly fast and with very, very low dosages of radiation. So for patients who undergo radiotherapy with especially mediastinal radiotherapy or breast cancer radiotherapy, for example, do you think that it would be reasonable to have a baseline CT coronary calcium score, which could then be reassessed, say, like in 2 or 5 or 10 years, just to get a grasp of whether there's a clear trend towards a quick progression of coronary artery disease, thereby enabling a more aggressive pharmacological treatment in advance.
I agree completely with you. As a matter of fact, I discussed that aspect with our colleagues of the primary care, and to include that exam in the follow-up screening, and they told me they could not ask for that exam because they were not allowed to have a prescription of that exam, and that limits that problems. That's why I just mentioned the electrocardiogram and the echocardiogram. Sometimes I have recently seen two patients that after a long follow-up period, she repeated the mammography, and in the mammography there was they detected the calcium in the coronaries. So they went back to the cardiology consultation. That's another aspect. But I agree completely. We should include that exam, especially in those patients, long-time survivors of radiotherapy.
Thank you.
Okay, if there's not further questions, we may proceed. Yeah, so let's proceed to the next session.
So now it's my time to present you. I think I don't need to make a formal presentation of Dr. Andrea Magalhães. And I asked her to take the floor. And I also, I want to present the panel for the discussion. We have two young cardiologists and a cardiologist to be, and a medical student, and at the end, we'll have a discussion. Go ahead, Andrea.
Good afternoon. This is the last session of our course, and it's dedicated to cardio-oncology education and training. First of all, I would like to take you on a journey through the evolution of cardio-oncology. So the first reference of cardiotoxicity was back on the 60s with the description of heart failure induced by anthracycline treatment. Since then, many other drugs have added to the cancer treatment, and many other cardiovascular manifestations were discovered. It's worth to remember that the first time that the term cardio-oncology was coined was in 1996 by Dr. Daniele Cardinale, an Italian cardiologist. 25 years passed, and nowadays the term cardio-oncology is much more present in the publications. In 2009, the International Cardio-Oncology Society was created, and it reflects a collaboration of experts from US, Canada, and Italy. And I think it had an important role to give more visibility to the cardio-oncology field. And through the years, the ICOs have grown, and nowadays it brings together people from all around the world. ICOs have promoted education too through different ways. One of them that I want to highlight are the webinars that started many years ago, almost 10 years ago. And more recently, the podcast. It's another way to share knowledge in the field. More recently, other societies have created councils and specific working groups of cardio-oncology. Such as the European Society of Cardiology, the American College of Cardiology, and the British or the Brazilian cardiology societies. In 2019 was the time for the Portuguese Society of Cardiology to create the working group of cardio-oncology. The visibility and the growth of cardio-oncology is reflected to in the presence of, in major congresses, sections about cardio-oncology topics. There is a congress entirely dedicated to cardio-oncology. It's the Global Cardio-Oncology Summit. It's promoted by ICOS, by the International Cardio-Oncology Society. And it is an opportunity for experts in the field to share knowledge and to identify gaps and needs for advance in the field. Through the years, both from cardiology and oncology societies have issued guidelines. And it's important to say that even the more recent guidelines, most of the recommendations are primarily based in experts' opinion rather than evidence-based data. So it's really important to perform research and in this field. Nowadays we have two journals dedicated to cardio-oncology, the CardioOncology from the BMC and more recently the JACC CardioOncology. And these journals are home for the much needed publication in this field. In cardio-oncology, we should focus on three main areas: clinical care, of course, but also research and education. And if we really want to improve the lives of cancer patients and survivors, we need to guarantee that the healthcare that care for these patients have the appropriate training. In 2016, the ICOS stated a consensus regarding the topic of cardio-oncology training. In this statement, the training was divided in 3 levels. Level 1, short-term training. Level 2, targets to cardiology, oncology, hematology, but also primary care physicians or internal medicine, with a duration of 4 weeks to have a basic knowledge of the cardiac complications of cancer treatment, both in the acute, but very important in the long-term setting. And level 3, there is a more advanced training with almost 1 year of training for cardiology, oncology, hematology fellows that really want to deep technology in the field. More recently, the CardioOncology Council, the American CardioOncology Council, have issued another statement in this topic. And the authors really highlight that there are so many cardio-oncology clinics created worldwide that we really need to pay attention to educate the healthcare providers and to try to standardize this training. So in this publication, they proposed requirements and core competences in the training in cardio-oncology. Another thing that's important is when we are talking about cardio-oncology education and training, we are talking about people that have different backgrounds. So it's important to cardiologists and oncology hematologists that really want to have more knowledge in this field to talk the same language. So for the cardiologist, it's important to have an understanding of the principles of cancer biology, general treatment approaches, the management prognosis of many malignancies, and to have an understanding of the different kinds of treatments: chemotherapy, target therapies, immunotherapies, radiation. bone marrow transplantation, and in the hematologists and oncologists need to have an understanding of the major cardiovascular diseases, our diagnostic tools, and also the pharmacology of cardiovascular drugs. So they highlight the core knowledge in the cardio-oncology training and the core competencies, and they keep the training divided in 3 levels. Level 1, basic overview in the topic. Level 2, a more advanced clinical experience for fellows in cardiology, hematology, and oncology with a duration of at least 3 months. And the level 3 training, the cardio-oncology fellowship, a more advanced training with a duration of 6 to 12 months. And that will provide a more exposure to inpatient and outpatient clinic, as well as the development of a research project. The EC core curriculum for the general cardiologists issued by the European Society of Cardiology in 2013 had a chapter dedicated to cardio-oncology, where the knowledge and the skills in this area should be. And it was really sad for me to realize that the more recent document only refers to oncology patients in the chapter of heart failure. So I think it's really a step back from the previous document. And as we all know, and we saw it through our course, cardio-oncology is much more than heart failure. So I really think that it was a step back to have this more recent document. And if we want to have a cardio-oncology fellowship, we can do it in the US. There are many places, also in Canada and in Brazil. In Europe, we only have one fellowship program in cardio-oncology at the Royal Brompton Hospital. I would like to say that the ICOS, the International Cardio-Oncology Society, had created a certification exam for certificate the providers that had an interest in and in experience and the adequate training in cardio-oncology. And in the last part of my presentation, I would like to share with you my personal experience in cardio-oncology training. So I got interested in cardio-oncology on the second year of my cardiology training. And as in Portugal, we didn't have any cardio-oncology clinic, I applied to a training, a short-term training in Vanderbilt University Medical Center. And I was there in 2014 with Dr. Daniel Lenihan. And to share with you what was this training, I had a clinical activity, mainly in the outpatient clinic, in cardio-oncology, survivorship clinic, the amyloid program, and also the oncology clinic, but also in patient consultation. Besides that, I was able to participate in ground rounds and in research projects and clinical trials, both in cardio-oncology and heart failure. I collaborate in contents for the website related to cardio-oncology and in the creation of an abstract for the ACC Congress. And and the first steps of the statement about cardio-oncology training was done when I was there too. So I think it was a very important and interesting experience. And after that, we in Santa Maria Hospital started a cardio-oncology consultation. And since the first time, we thought that it was important to contribute to education through this course. And I would like to end this presentation by looking to the future, and especially in Europe and especially in Portugal, what we can do to improve education in this field. So I'm looking forward to have this discussion with you. Thank you so much for your attention.
Thank you, Andrea, for such a clear presentation. And now I want to ask, what can we do to implement cardio-oncology training in our hospital, for instance, or in Portugal? What's your suggestions, your opinions? I think it's time to hear the panel. Let's start with Mariana. Hello, Mariana.
Hello, good afternoon, everyone. First of all, I'd like to congratulate you for another very interesting course, and to thank for the kind invitation. I think that first of all, every hospital that provides cardiology and oncology care should have a cardio-oncology consultation, and that's not already a reality, at least throughout our whole country at a national level. That should be the very beginning, I think.
Yes, we all agree with that. But what could we do to implement in practical grounds a cardio-oncology training? What's your opinion, Andrea? With your experience, we can take as the basis our cardio-oncology, our postgraduate cardio-oncology course. Could we do it? We could put it in the internship, for instance, and go step by step. I wouldn't say that was such a structured cardio-oncology training as you had in the United States, but adapting to our reality. What could we do to start with?
First of all, I just want to highlight that I think this is an important topic because we see first in the US and now in Europe and Portugal too, the creation of many cardio-oncology consultations. And so it's important that we guarantee that the people have the basic knowledge and the knowledge to take care of these patients. So I think it's important to talk about the training, but it's a very difficult question. I think that, we both belong to the working group of the Portuguese Society of Cardiology. And I think that this working group can have an important role in this, in the implementation of its training. Such as we see the Academia Cardiovascular that we have on the Portuguese Society of Cardiology. I think other initiatives like that will be important to raise awareness to the team. And I think that we have students. We every week have a group of students, and I think I realize that they are not really aware of the cardio-oncology and these things that we are discussing. So I think it's important to involve the universities and especially the cardiology departments of the universities to have to introduce this theme, these topics during the medicine course. In what concerns cardiology training, I think it's important to the fellows, to the residents, have some knowledge in this area. I don't know exactly how we can, because in Portugal we don't have a specific training for other areas too. For instance, the residents don't have the obligation to go to heart failure, for instance, heart failure consultations. So it's difficult to introduce an obligatory time period for the residents to be on cardio-oncology clinics, for instance. So I think we should start with the lectures about it and to involve the working group of the Portuguese Society of Cardio-Oncology in this. It's my take, but I want to listen to the panel and we have 3 colleagues that I would like to know how they got interested in cardio-oncology, and maybe they have other takes in this topic.
Yes, I agree with you, and I want to hear the opinion of Diana Duarte, which is a medical student. Anyway, we already have a seminar on cardio-oncology for the fourth grade students, medical students. That's the beginning. Mm-hmm. And but as you said, the medical students don't know nothing about this. But as a matter of fact, there were some medical studies students registered in this course. But that's the beginning. So let's hear Anne-Isabel.
Okay. First of all, I would like to start by thanking the invitation to be part of this panel. And I absolutely agree with Dr. Andrea. Once that the knowledge in this field and the talks that we have access during the medical program, I think it's not enough to establish knowledge, effective knowledge, and to establish curiosity in the students. So we already have in the cardiology in the 4th year seminar, but I think maybe we could think in some like more like a program, a specific program, for instance, in this area. One that students can apply, interested students can apply, and I think that could be a good beginning. And maybe I would say that oncology we have a program of oncology, oncobiology in the 3rd year, and maybe this specific field could be introduced in this program too.
Okay. Yes, I think it's a very good take, or an optional. I know that during the course, during the medicine course, we have some options for take in some disciplines. So I think, yeah, I think it's a good idea to implement that. And about Beatriz, Dr. Beatriz Silva, what's your take on that?
Hello, good afternoon. First of all, I would like to thank Professor Manuela Chiusa for inviting me to be part of this discussion and congratulate the organizing committee for the excellence of this course. Well, Andrea, in the sequence of your question, I think that my interest in cardio-oncology started even before I ingressed in the cardiology fellowship. When I was in that about to choose cardiology or hematology after graduating. Well, about this question, I will start with a brief comment and then I have a question for you. Considering that both the cardiovascular disease and cancer are leading causes of death, I think cardio-oncology is a growing area. And it's curious to note that, as you say in your presentation, that the ESC curriculum introduced for the first time the topic of cardio-oncology into 2013 and even in 2020. This document actualizes and reinforces the importance of cardio-oncology, although we could expect more. So my question or my opinion is that it's mandatory to include cardio-oncology in formation in general cardiology training programs. And I think this could be done by incorporating educational topics and sessions. And this course is an excellent example of this. And in addition, I think that particularly in centers with established cardio-oncology programs, maybe doctors in training should be included in an organized rotation for several weeks, depending on the possibility of the services or formation program. And I think it could be really benefit for our formation. Well, my question is, there is no doubt about the role of a multidisciplinary team in cardio-oncology, including the cardiologists, oncologists, hematologists, and probably the internists. My question is, there is a role, as we have discussed in previous presentations, for primary healthcare management in these patients. So particularly in low-risk patients. So my question is, how can we involve family doctors in this process, and what kind of training should they receive to help everyone to better manage these patients?
Okay, I think it's a good question. Absolutely, the primary physicians have a role in this, and they usually spend some time in the cardiology clinics. And in our center, we sometimes receive colleagues, doctors in training in medical family medicine, and I think it has we have to take that opportunities to get awareness for them about cardio-oncology. I don't know, because they have only very few years of training. So to introduce in the training, it has to be an optional time for them to decide if they want to have this training or not. Yeah, but I think it's a very good,
Can I make a comment? So I agree with Beatriz. I think that at least from a cardiology resident point of view, when we have these cardio-oncology teams available available, it should absolutely be mandated to participate for a short term period of time. And of course, we should have some kind of training, even if it is only theoretical sessions, conferences, what is available. But I think that this training theme is much more complex, especially when we take into account what you've presented, that also there's another way to achieve this training with an oncology or hematology background. And I think that's a lot more challenging also to train these other colleagues that have other kinds, that have another background, that need to have training with very specific cardiology subjects, namely imaging exams and all of that. And I think that's quite challenging also. I don't know exactly how we could also provide that that type of differentiation for them. I don't know if you have an opinion on this.
I don't know if Professor Manuela wants to
Yeah,
say. Or...
Actually, we had two fellows, of one of oncology and another from hematology, in a short term, I think during 1 month. I agree that we could provide an optional training for a short period to different specialties that could be primary care, GP we already have, probably for oncology and hematology also, and for a short period as an optional for our cardiology fellows. That is just a suggestion. But I agree completely that we have to alert and have awareness of our medical students. I think we should begin with the medical students and then go step by step and implement and organize in our working group, for instance, and organize and those formatting programs. I agree completely. Until we don't have a more structured future programs, because we have to go step by step, is my opinion. I think I don't see in the short term we have such a well-organized program, cardio-oncology program, as you have in the United States, or even here in Europe in the Brompton Hospital. So let's look at the future, but meanwhile, we should do something, and that something could do those programs, the working group of cardio-oncology, and alert our medical students for the problem. I don't know if you agree, but that's my opinion.
Yeah, absolutely agree. And just to probably to finish up, I just want to say that I think cardio-oncology is a very interesting field, and for those who like investigation, to do the research, I think it's an exciting field with many gaps in knowledge. So I think that if some our residents see that potential, maybe they want or they seek more attention to cardio-oncology.
Can I just make a very brief comment, Professor, as well? So I'd just like to grab what Andre just said, and this is really an area that's still very much in its infancy. There's a lot of buzz, but if we were to do guidelines on cardio-oncology today, there wouldn't be a single A-class recommendation. I mean, we would have mostly C recommendations and a couple of Bs. And so that's actually something that I think can be very challenging very challenging, but very interesting for fellows, because this is one of those fields that you can build the field while you're training. And there's actually there isn't any other place in cardiology that's quite like that. And proof of that is that Brompton has the only fellowship that we currently know of. And so I think that it's certainly one of the biggest appeals of the field. And during residency, I guess that the time frame where you have the chance to grow a lot and build on that is during the optional training period. That's really like Andrea did. And so, but I do think that it's an area of a lot of potential growth where research is perhaps the single most important thing that one could focus on.
That's a very, very important comment, Miguel. And I think our three cardiologists or cardiologists to be are in that field of research, either clinical research or basic research, right? And Isabel is in basic research, for instance. Can I have your opinion?
Yes, absolutely. These cardio-oncology programs and updated courses are very important, and the importance of the clinical or basic research in this field is absolutely important. Once more, currently I'm doing research in this field in a more basic way, trying to conciliate with clinical research too. In cardio-oncology, in cardiotoxicity and autonomic dysfunction, in breast cancer field and anthracyclines. And I think the gaps that exist in this field, I agree with Dr. Andrea and Dr. Manuela and Dr. Menezes, once that with research we could fill the gaps and in the end of the day finding answers to treat better.
And Mariana had his master's degree on cardio-oncology. Do you want to make a comment too?
Yes. I actually ended up choosing cardiology as a specialty because of that master's thesis, my final med school assignment. At the beginning, I was actually interested in oncology, but then the project that was proposed to me was on cardio-oncology, and I ended up choosing cardiology because of that project. So that was very important to me, and that, as you've said, that started for me as a med student. And what I've been trying to do, I'm currently an intern in a non-tertiary hospital, but we have already started our cardio-oncology consultation. And what I've been doing is I've been trying to participate and collaborate and help establish protocols and keep some kind of clinical research in my small hospital, and try to end up being trying to keep my interest and curiosity in this theme in my hospital. Now as a resident.
Thank you. And Beatriz is a new acquisition, a very promising one. Can you give a comment, please?
Yes, as you said, I have been involved in cardio-oncology more recently, but I've been very happy with this, and we have already some ideas for developing some topics on research, particularly clinical research, such as echo parameters, and so I think that this is a promising career.
Okay. I think there's a question in the
comment.
The comment. There's a question. It's a comment. Can you read it? Yeah.
Yeah, from the hematology perspective, I think the creation of the cardio-oncology group has been very useful, and my colleagues are more alert to referring patients to cardiology. It's from on hematology, Joana Vieira.
Okay, that's good.
Yeah, it was our hope, and it's very good to hear that.
So, if you agree, we can end this session. Do you agree?
Yes, yes, I think so. We are already
a
little delayed, so yeah, I think so.
So, we reached the end of this fourth edition of this postgraduate oncology, cardio-oncology course. And I think we had a terrific course, and I hope to see you next year. We're still thinking about it. And thank you all. And just a last remind, you have the link for the quiz in the box, okay? For those who want to make the quiz, the link is in the box. So bye-bye, and thank you very much. See you next year. Thank you.